go for surgical repair for this patient. What about rib fracture? Rib fracture is an uncommon in children, but you think about it can be happen from crash or squeezing mechanism, or secondary pulmonary contusion, pneumothorax, or hemothorax can be present with the patient with the rib fracture. Think about child abuse. Up to 50% of isolated rib fracture may be missed, may be necessary to go for CT scan. It's very important to make good management for the pain and using the sensitive spirometry sometimes to help to decrease the severity of the pain for this patient. Plial chest is the patient presence of that's more than two fracture in the same ribs, causing the rib of the plial segment to be moved paradoxically, and they can cause respiratory distress and hypoxia and paradoxical chest wall motion. That's chest exercise is very helpful. You can see sometimes a pulmonary contusion with this patient. You can make positive pressure ventilation until that operative rib fixation for this patient. Spine injury, I will not go for this one. I mentioned and explained for this one in the previous lectures. Very important. And as I mentioned for you, square and this one and how to deal with this one in the previous lecture. Cardiovascular injury with this patient is uncommon in children, but it can be highly morbidity and mortality associated with the thoracic trauma. It can be present with the patient with the myocardial contusion, which is secondary to the blunt chest trauma, cardiac tamponade, penetrating mechanism can happen, one of the scenario can happen. Other injury can be happen for this patient as a secondary complication include myocardial laceration, pericardial laceration, valvular disruption, myocardial necrosis, and subsequent aneurysm, traumatic aortic insufficiency. This one be present with a coronary artery injury or cardiac conduction system is injury for this patient. Myocardial contusion is not common at thoracic trauma, but one of that common presentation of the if there is any trauma to the heart. That's most common and suspected and underdiagnosed injury after blunt thoracic trauma. Increase the severity with the multi-system trauma. Motor vehicle accidents that or pedestrian injury can is the common presentation and cause or mechanism for that presentation. Chest pain, he is present with tachycardia, dysarrhythmia, and hypotension with sign of cardiac failure with this patient. Myocardial contusion diagnosis should be made using that combination of the clinical suspicion and clinical examination to finding with the cardiac-specific evaluation for this patient. You can go for ECG, echocardio, troponin, other muscle enzyme to rule out this patient if he's cardiac traumas. Supportive treatment, children should be admitted for observation, cardiac monitoring for serial measurement of that cardiac enzyme for this patient. Cardiac tamponade, you can see in this picture, this is some fluid surrounding of that patient, and sometimes the effect of that feeding time or preload for this patient is life-threatening condition, and the blood or a serious fluid fill that pericardial space and compression of the venous retain. Secondary to the penetrating injury of stab or gunshot wound or pericardial wound for this one present with the tachycardia, narrow pulse pressure, patient pulse paradoxus, clinical combination of that's muffled or distant heart sound with hypotension and jugular vein distension that can this triad is a big triad. This one can help you to diagnose patient with the cardiac tamponade. Cardiac tamponade diagnosis is made clinically. You can go for echo, it's very helpful, or ultrafocus, ultrasound, chest X-ray, and ECG. Immediate bedside needle precardiosynthesis. Thoracotomy with precardiectomy or thoracotomy and the repair of that underlying injury is very important in some cases. Repeat precardial aspiration and aggressive blood resuscitation for this function is very important. Aortic injury is extremely rare, but you can think about it. It's the level of that ligamentous arteriosum, and that's most common injury with the children. Mortality more than 50% of the injury patient would dying at the scene. A blunt aortic injury, rapid deceleration, high speed motor vehicle accident, and fall from the greater heights. Chest pain, patient who has maybe murmur, this patient with associated with heart and lung, abdominal, and CNS injury, multi-system injury. Chest X-ray is widening of the mediastinum. The CT scan is very helpful for with the angiography. Initial treatment with the ABC with this aggressive resuscitation and pneumothorax should be treated promptly with aggressively. Definitive treatment required immediate with the surgical repair for this patient if you want to avoid any severe complication can happen with this one. Comatocordius, this one happen if there is any direct trauma to the chest wall, and that trauma, if it's happened, this patient in the T wave, the big T wave, that one can cause the patient, he's maybe developed ventricular fibrillation. Is the good prognosis if you discover early and start management for this patient and help to reverse that ventricular fibrillation to normal rhythm for this patient. Child abuse or non-accidental injury is serious concern. Rib fracture are the most common thoracic injury, triple and the rate of the general pediatric population. The emergency clinician must be have elevated the index of the suspicion of non-accidental trauma when they're treating a young patient with the rib fracture, or sometimes if isolated rib fracture, first rib, especially concern of that abuse with this patient. I will go through the last part of my talk in this cases. We have to talk about some procedure like needle thoracostomy. You can keep the patient supine position in second intercostal space at the mid-clavicular line in the affected site and attached to the syringe filled by the 3 ml saline with the angiocath or butterfly needle. While maintaining the negative pressure to the syringe, you can insert that needle or catheter and advance it. During that, there is bubbles or there is air bubbles coming out, and you can visualize the syringe or audible rush of that air is detected in that syringe. You can see in this one, he just auscultate. Now you find there is diminished of the breath sound. Now there is pausing. So now he will start to make needle decompression. This is the syringe. He opened that catheter. Now he fix it. Okay. Then you'll fix it this one. And you will palpate for the second intercostal space in the mid-clavicular line. Okay. Now you will try to make decompression for this one. He cleaned this area before he start to insert the needle or advance the needle. Now you will advance the needle. Then you can see if you advance the needle, you can see when you make pressure, negative pressure for this one, you can, with the 3 ml saline, you can see some bubbles coming out. Tube thoracostomy, it's in patient you can keep in supine position, select the appropriate size catheter, just a tube, and prepare the patient to appropriate analgesia and sedation. You can make localize the insertion site at the 4th to 5th intercostal space, just anterior to the mid-axillary line for this patient. And to drain air should be directed anterior if you want the drain the pneumothorax, or drain fluid should be directed toward the patient back. Make a small skin incision parallel to that intercostal space, and post incision chest axillary can be find this one and to confirm. Now he make in the fourth intercostal space, make incision parallel to the intercostal space and the intercostal space for this one, and he try to insert that. Okay. Now you will ready, and he make local anesthesia before he start making this incision. Now he holding the tip of this chest tube. Now he try to find the way of that tube, and he direct the probe and insert it and advance the tube. Depend if you want to make drain air, you can anterior. If you for fluid, you can, or blood, you can make this in the gravity or in the back. Precardioccentesis is one other important technique and procedure you have to be familiar for this one, is for the infant or young children. You can start with the 20 gauge spinal needle, around 1.5 inch, or 18 to 20 needle for this patient. Insertion site of that anterior chest wall immediately and inferior to the xiphoid process. Will go a little bit 1 centimeter left side to the xiphoid process, while applying the negative pressure to the syringe, advance the needle at 40 degrees. This guided, you have to be guided by ultrasound or echo to avoid any injury to the heart. Angle is 45, direction to the tip of the patient left scapula until that pericardial fluid or blood is obtained, until the ECG change or exchange or any that's needed will be make good injury for that heart. You can stop your procedure. Place that patient on the cardiac monitor and position patient in the slightly reverse Tintenberg position for this one to give that good gravity to accumulate the fluid. Use ultrasonography to visualize that precardial fluid collection and prepare for sterile surgical field, and use the local anesthesia and sedation for this patient. Now, this our patient. He will start his technique, subxiphoid, this one. You will insert the needle just 1 centimeter lateral and direct it to the left angle of the scapula, and try to fix that needle and advance this needle guided by ultrasound. You see this is needle tip, and we make good penetrating to the precardia, and you will start aspiration. But you have to be guided by, you can see the tip of the needle, okay? And you stop that procedure feeling like this, there is an ECG change, or you think this will be make injury to the muscle of the heart. Then you can make pressure. You can keep that needle, yeah, to make drain of any fluid will be accumulated later. You can drain till that's stop, no more any blood or any fluid coming to that needle later on. You can stop this one and can remove it. This one will be helped too much for that patient present with a precardial tamponade for this patient. Our case is 4 years, as mentioned, patient whose blood pressure was dropping along that motor vehicle crash. You perform the fast exam and the precardial, particular emphasize on the point of care cardiac ultrasound. You found that he had large precardial effusion with the resultant the cardiac tamponade, and giving that hemodynamic instability for this patient. That can explain why he's unstable blood pressure, and can explain what his patient he's drop in the blood pressure. He has a tamponade, and so that patient um, going precarditis. So patient after that he's improved for this patient. Next talk for me is very important topic. You have to be more familiar with this one. The EFAST. EFAST, one of that skills you have to be, everyone is working the ER, you have to be more familiar for this one. Also, it's very important to know what's meaning fast. It is focused assessment with the sonography in trauma patient. That will be give impression about if there is peritoneal space, if there is any fluid, or pericardial space if there is any blood. So it's very important. Extend fast or e-fast will be add impression about hemothorax or pneumothorax with that patient. If the patient present with the after crash or injury or trauma, so it's very important to know this 10 years old male with motor vehicle accident. He is present to by AMS with collar and backboard. He's awake and agitated. Patient is maintained, patent and maintained the airway, and equal air entry bilateral, oxygen saturation is 85 and respiratory rate 30. A patient, his cold extremities and blood pressure is 85/50, heart rate 140, and no external source. There is a contusion to the left upper abdomen. Injury diagnosed for this patient. Maybe he has abdominal trauma, maybe he's pleural, or there is any pericardial hemopericardium, or pneumothorax, or cardiogenic shock secondary to tamponade, or defibrillation disrupt of this one, or direct trauma to the heart and make cardiogenic shock secondary to the contusion to the heart. Maybe is related to the neurogenic secondary to the cervical injury for this patient. So it's very important to have some tool to help you if you fail by physical examination or other modality of that approach to approaching what's the cause of that dropping of that blood pressure, or how to manage this patient. Physical examination is low sensitivity if the patient distracted by injury or low mental status for this patient. So it cannot be helped for this one. If you go into DBL mentioned by Dr. Muhammad, he is no longer used for this DBL for this one because low specificity for this patient. So CT scan also patient, he's not a stable patient to go for CT scan. So we have to find other modality can help for this one. We'll go for ultrasound. And you can see that pros and cons for this patient. He's very accurate for this advantage and portable, non-invasive, and no radiation. But you're feeling some important point or disadvantage with this one, not specific for this one, and type of fluid. You cannot decide if it's hemothorax or patient secondary to ascites. And also depend on that operator dependent and doesn't detect retroperitoneal injury for this patient. Our goal for this one to find free fluid in three space in peritoneal, pleura, and pericardial space. That's our aim on that study or EFAST, looking for the sign of that pneumothorax for this patient. FAST is useful for non-trauma situations, like you can see the patient present with the FAST if it does not trauma, like if we want to speak about the adult, like rupture ectopic pregnancy or rupture of uterine cyst, or patient maybe secondary with the renal disease or the present with the ascites with this patient. How to start? You can start the patient with the right upper quadrant with this patient. You can see if there is any peritoneal free fluid or there is any pleural free fluid. Then left upper quadrant, peritoneal free fluid and pleural free fluid in the left side. Then suprapubic to find any peritoneal fluid or there is any pelvic collection in the pelvis area. Subxiphoid is very important to rule out any precardiac fusion for this patient. Okay. Then later on, after finishing for all this one, you have to rule out patient he has sliding or chest lung point. If this to rule out any pneumothorax in the left and the right side. What transducer you will use? Usually you need to use or utilize that curve linear because you need to make more penetration. But if you want to scan a patient in the chest wall, you have to utilize that linear one and high frequency for this patient. Okay. Let's start about the technique. What's the technique for right upper quadrant? Upper quadrant, you have to make mid, you can see this mid axillary line at the level of the xiphoid process for this patient or in the below the costal margin. You can slide the probe up and down to find that kidney and Morrison pouch. البروب marker of the marker familiar, you have to be more familiar for the probe. You have to be direct to the head for this patient. And if you find that kidney or liver, you can make good fanning to find and good scanning for the Morrison pouch. What you can see that kidney and you can see the liver. The Morrison pouch will be between the liver and the kidney. Try to keep that probe little bit oblique angle or oblique 10 degree to go with the long axis of the kidney. Then you can make good fanning to not missing any part between the liver and the kidney. If there is any black between the kidney and the liver, that's fluid. The fluid is positive, that's fast. Don't forget to scanning and looking for the inferior part of the kidney or inferior pole for this one. Okay, and also some literature, you have to also visualize the edge of the liver to be sure no any accumulation of any minimal fluid for this patient. Okay. You can see fluid in the Morrison pouch in this area, or in this area, or in the other area, this one. So it's very important. Or we can find this one between the liver and the diaphragm. Now, you can see anything? No. You cannot see any accumulation or fluid in that area. So it's negative for this patient. But in the other video or clip, you can see some black. So it's positive for this patient. So this patient, the kidney, this is the kidney, and this is the black is positive with the Morrison pouch. Okay. Now, this patient, secondary to stab wound, the chest wound, you can see fluid, the black, you can see here. And this is the liver. Okay. Also, you can see patient after 2 days ago, you can see free fluid for this one. One of that obstacle for us, very important 2 point. the color of that blood will be changed within the time. Maybe will change from an aqueous, يعني from black to be like liver color, or increase the echogenicity of that clotted blood. Sometimes make that's difficult to the judge of this patient. He has hemoproteinium or not. Also, other important some fat surrounding that the kidney can present some anechoic, can be false interpreted this one as positive, and he's just only the echogenicity of the fat for this one. Also, as I mentioned in the beginning, for this patient, he is maybe present with the ascites. He can give impression for this patient, he positive fluid, or maybe positive fast for this patient. Okay. As I mentioned, the rib black. If you want to go for better and bitfold for this one, in black in your view, rotate the probe just clockwise and fan forward and backward to find good imaging. Other important, the gallbladder can give you impression there is fluid. Don't be mistaken, label this one as a free fluid for this one. For this is the gallbladder, or sometimes an IVC. You think it is IVC or gallbladder is positive fast for this one. So we have to be more familiar for this one. Also the perinephric, you can see the perinephric I mentioned before. Sometimes hypoepic can give impression of that patient. Maybe think about in patient he has blood or positive blood or hemoprotein, and just only this patient he has only fat. So if you are mistaken with this one, you can just compare this one to the other side for this one. Just to remember this one, and this is the positive one. This is the gallbladder with the IVC. This patient with the fat or sheared fascia. Right upper quadrant, now slide the probe upward, looking for a fluid. Yani just when you just finish from that part of the kidney and make good fanning for muscle pouch, you can slide the probe up to visualize the pleural disease. If you find if there is patient, it is positive fluid above the diaphragm, this one. Normally, if that's spine, this is the spine, this is the diaphragm. With the spine will stop at this level. You cannot see the spine above the diaphragm. If you can see the spine above the diaphragm, that's meaning this patient he has positive spine sign. That can allow that beam of the sound can crossing the thoracic, and you can visualize the spine. So if the patient, you can see spine sign, that's meaning maybe he has hemothorax or pneumothorax, hemothorax, or maybe patient he has pleural effusion, or maybe he has consolidation that's allow that penetrating of that beam of sound can visualize the spine above the diaphragm. So that diaphragm, this is the normal. You have cannot be see the spine or bump in this one. You cannot see above the diaphragm for this patient. Okay. Now you can see this one image. This is the IPC. This is the diaphragm and the spine. You can see that the spine is stopped at the level of the diaphragm. So it's normal. But when you see this one, you can see the spine above the diaphragm. This is the diaphragm, and this is the spine. You can see the liver. With this picture, you can see the fluid above the diaphragm. This maybe this patient, he has fusion or hemothorax. Okay. What about this one? This is the spine. Okay. You can see anything? There is, but positive, but sometimes can be changed with the time that blood to be increase the echogenicity, but positive spine sign. You can see the diaphragm, and you can see the diaphragm, or sorry, spine is above that spine. After finishing from right side, you can go for left upper quadrant. This left upper quadrant you can do like what you did before, but this is more posterior and superior than the right upper quadrant. A probe marker toward the head, fanning forward and backward. Okay. You can see the spleen. Okay. If you feel any fluid or positive in the splenorenal or in the above the spleen or between the diaphragm and the spleen, or maybe between the kidney or renal or splenorenal. So it's very important to be more familiar with this one. You can see now the spleen, the kidney, okay? Nothing you can see there. But if you see this other one, there is fluid between the diaphragm and the spleen. So it's very important, very interesting. You can see also there is fluid between the kidney and the spleen. Okay. If you same what you did before on the right side, but it's very important to avoid the ribs by clockwise to avoid the rib shadow for this one. Pelvis is very important, and you have to make good scanning. Direct the probe to toward the feet above the symphysis pubis. You have to scan the patient with the sagittal. Sagittal will be the probe direct to the head. Transverse position will be directed to the right side of the patient. The male one, you can see behind the urinary bladder, and female you find this behind the uterus. Now, let's start. You can see this one, transverse position, and this is longitudinal view for this patient. You can see this like trapezoid shape, this is wood shape of that longitudinal view. So you can see now how to be cut. This is by ultrasound. You can see that urinary bladder. In the posterior to this one, this is the, if you are speaking about male, will be vesico-rectal reflex. Sorry, recto-vesical area. You can find that accumulation of the fluid. So it will be accumulated posterior to the bladder for this one. Okay. So you can see that transfer position, and you can see that fluid between the rectum and bladder. You can see that positive fluid or black area. Sagittal one, same, but will be more familiar with this one, will be accumulated as I mentioned for this one, but will be cut this one in the direction of that probe to the right side. Sorry, to the head as a sagittal cut. You can see that black area more posterior, the bladder. Okay, this is the sagittal type. You can see that fluid. Okay. Also, this one transfer position. You can see also that's fluid in the pelvis area. So this is transferent to longitudinal. This is ectopic pregnancy, and you can see that missed period, and you can see that fluid accumulated in the pelvis area, and you can see the rectum. Sorry, the uterus, and this is the urinary bladder. You can see a lot of blood or positive fast. This is the transverse position. You can see the fluid for this one. So useful to be even in non-trauma cases, and you have to be better to be performed this full urinary bladder to help to as acoustic uh, guiding for posterior to the bladder to feel there is patient and there is any fluid or not. Subxiphoid, you have to keep the probe more flat, directed to the left shoulder, and keep the marker to direct to the left side of the patient. Okay. If you keep the probe like this is perpendicular, you will not feel or you cannot see that heart. You have to keep that that the probe is more flat, attaching that skin for this one. Now you can see the heart. This is the anterior part and this is the posterior. You can see that right ventricle and right atrium, left ventricle and left atrium for this one. If there is any fluid, will be accumulated in this area. If there is tympanoid, will be surrounding of that the heart for this patient. Now, this is the long axis for this patient. You can in the fourth intercostal space. Sometimes it's very helpful. If you doubt about subxiphoid, you will not visualize the heart clearly. You can go the long axis to visualize that heart. You can see that right ventricle, you can left ventricle, and you can see how is the heart squeezed. And if there is any fluid, or precardial fluid, or precardial fusion, or hemopericardium, it can be anterior to descending aorta. You see this descending aorta will be the black will be in this area. If you posterior to the descending aorta, that's when going with the pleura. It's not going with the precardium. You can see that fluid surrounding the heart. If surrounded for heart from all that from anterior to posterior, this one it will maybe affect the heart and maybe can cause tympanoid. But you know that tympanoid is more clinically than to be judged by that ultrasound. Now you can see that precardium or hemipericardium is around the heart and surrounding the heart for this one. Also, you can see in this video is very interesting video for this one. This is the descending aorta. You can see the fluid in this area. This is hemipericardium, and this is descending aorta. We can see also there is fluid posterior to the descending aorta. This one can call this one as hemipericardium, hemothorax. So this hemothorax, hemopericardium. So how can differentiate it? By this descending aorta. Is anterior hemopericardium. Posterior, this related to the pleura, so is hemothorax. So to improve your image quality, increase the depth. If you're feeling some difficulty to scan of that patient, slide the probe more to the right, ask the patient to be inhale, bend the knee to help and to keep the heart close for that scanning. Even small hemopericardium can be caused tympanoid. Pericardial fat maybe looks like the pericardial fluid. Now you can see pericardial fat. Okay. If you find just only in the anterior, no any black or no any fluid in that posterior, most likely is fat bed. Pneumothorax, as you know, by linear one, high frequency probe. Place the probe longitudinal in the anterior chest wall, hold the probe in position. You can see the sliding probe for this one. This is the commutator. You can see like flash, small flash coming from the pleura. This is the pleura, and this is the subcutaneous tissue. And you can see this is the rib and the other ribs. This intercostal space, you can see that sliding forward and backward. Okay. If you cannot see anything, that's patient, he has pneumothorax. There is no movement here, no sliding. So what do you think? So you can differentiate this one, sliding without sliding or no sliding for this one. So it's very helpful. But if you find this is case like this presentation, you have to looking for if there is lung point or not. This is good sliding, but this is lung point. You can see there's no sliding here, and there is a sliding in this area. So there is lung point. What's meaning lung point? Lung point is starting point between that sliding and no sliding. So if the patient is no sliding, you have to looking for if this patient has lung point or not. We'll go in the summary. Right upper quadrant free fluid. Okay. Hepatorenal interface, this one, or Mosen pouch. Caudal tip or caudal, this one is very important. Also the tip of the liver, between the liver and the diaphragm, inferior ball of the kidney and pleural space for this patient. For right upper left upper quadrant, free fluid can be superior or lateral or to the spleen, or splenorenal interface or pleural space for this patient. Subxiphoid, or sorry, suprapubic male behind the urinary bladder, or female behind the uterus in the pouch of the Douglas. Subxiphoid, there is a free fluid in the precardial space. And then after that, you can see the pneumothorax and normal sliding, good sliding for this one. And you have to find this patient with lung point. If you go back to our case scenario, we did for this patient, no pneumothorax, no free fluid in the right upper quadrant, and no any precardial hemopericardium. But when you go to the spleen, you can see free fluid or accumulation of the blood around the spleen, or there is a fracture in the spleen for this patient. Also, you can find this patient no any movement, no sliding, this pneumothorax. Also, you can see suprapubic, there is no any fluid for this patient. Okay, so left pneumothorax, free fluid in left upper quadrant. So chest tube done for this patient, blood pressure and heart rate after receptor this one, home to the OR, and patient is improved after ventilation to the OR. Thank you. So thank you. You can go for break. If you have any question, you can keep this one at the end of my the end of the third session for this one, and you'll go to our lunch break. We'll back at around 1 o'clock sharply to start the third session for our activity and course. Thank you. We'll start now the third session for our course. We'll start it very important, and you have to be anyone who was working in the emergency. You have to be more familiar about how to approach with the patient with the acute trauma wound in the emergency, and how to deal with this one. What you have to do, what's the skills you have to learn. Okay. In the end of my talk, you have to be cover most important how that wound healing, mechanism of the injury, and what's the phases of that wound of healing, and the emergency department evaluation, and what's the how to close that wound and what's using anesthesia or local anesthesia, you have to do it in your field. What type of suture you have to do it, and special circumstances you have to be at the end of my talk. In the beginning, I didn't have any financial disclosure or that's conflict interest on with the presented material in this presentation. As you know, traumatic wound are common presentation in the emergency department. Approximately 7 million patient is visiting the United States to the emergency department. Yani, one laceration every 4 seconds for this presentation to the ER. It's very common. More than 5% of that emergency visits is annually for this patient. The most common location of laceration usually in the upper extremities around 35, followed by that space around 28, at the trunk 40.5, and lower extremities is around 12.5. The head and neck is around 10%. The complication of that wound care may lead to the malpractice. What's very important and very crucial point that you have to be focused about this one. It is malpractice claims in the court usually as missed foreign body or wound infection or joint capsule violation or failure to detect the nerve or tendon injury. During that, when you make good closure for that wound. Let's start with the mechanism of the injury for this patient. You know, you have to familiar for that anatomy or the histology of that for this patient. We present with this patient with the skin. You have to be familiar. This is epidermis and dermis and hypodermis for this one. It's very important to be more familiar for this one when you make good suturing for this patient. Usually, patient present with AR as a mechanism by penetrating trauma or cutting trauma or blunt trauma or just secondary to puncture wound. Usually the puncture wound for the sole when he's just step on this one, and usually in the sole of that when you just running or stepping on that foreign body. Also, there is also can be present with the mammalian bite for this one, dog bite or cat bite. This can be present. Usually, the classification of the minor injury, maybe he's present with the shear force. You can see clean cut for this one, sharp, with minimal or linear type, okay? Or maybe present with the compression type, okay? You can see like blunt right angle for this one. You can send it to the hammer or this one blunt right angle. You can be just moderate damage, and you can find like satellite jagged margin for this one, and maybe make difficulty to suture or closer for this like type of wound. The third type, this tensile type, this one present with the blunt oblique angle, usually with the moderate damage or to the for skin and epidermis for this patient or subcutaneous tissue, present with like a triangular flap. So also can be present like this. You can see that flap, and there is you have to any patient present like this is presentation. You have to be more familiar how to deal with this one and how to close it. What's the phases of the wound healing? Wound healing is divided into 3 phases. All that our first phase is hemostasis or inflammation. this will be aggregation and the granulation and activation of the other coagulation cascade of the lead to the fibrin clot formation, neutrophil. This one enter the that's wound and macrophages. This patient then will be going to second phase. Second phase is begin at the fourth day, last maybe 21 day. Like this is proliferative disease phase. This proliferative disease proliferative phase is this fibroblast endothelial cells become more active and synthesize that deposit collagen and formation of the new capillaries. The last phase, that's when happen like maturation or remodeling of that wound. That's the newly synthesized that and deposit collagen begin in the organization of that wound and try to change that previous one. So any patient present with the emergency with the wound, you have to make good history for this patient. How's that mechanism of the injury, time since injury, past medical history like hemophilia or diabetic or renal failure or obesity or malnutrition or immunocompromised. There is a history of allergy. It's very important to be sure about tetanus vaccine or allergy to that some anesthesia. Physical examination is very important to where is the location, size, depth, and shape. Wound should be also be examined from that sign of the contamination. It's very important from body infection or the fertilized tissue to be sure no any active infection to need to be clean. This one. Neurovascular status is very important. You have to be examination of deeper structure. You have to make good exploration for that area to find if there is any structure such as tendon or muscle or bone is involved in that lesion, because sometimes you close that area and at the end of that suturing you find some cut in the tendon or in the nerve or the other structure. You are not clear in that presentation. What laboratory study you have to be do for this patient? Usually no, rarely to be required for any patient present to the ER. What's the image you have to start? You have to imaging a study for this patient up to 38 of that patient to rule out any foreign body, retain foreign body missed in the initial physical examination or delay in the management of the foreign body maybe lead to complications such as infection or delayed wound healing or inflammation or loss of the function of that area. So what you have to do, like if you suspicion of that foreign body, ultrasound is useful for detecting of radiolucent foreign body. Emergent MRI, CT scan sometimes we may indicate of this there is a concern of neurovascular compromise or this cannot visualize the foreign body. What about the treatment? Patient with the laceration and prioritizing return to the normal function, avoidance of that infection. You have three important methods to use to close the wound, as to be primary or secondary or delay primary closure. Primary closure, as you know, acceptable to proceed to that closure of that time of the presentation of the full thickness wound of the suture by staple or by suturing or by adhesive strip or tape or maybe surgical glue. There is low risk for infection as well as little concern for that wound edge separating due to the tension of that incision line. But other important thing, if there is any suspicion of that patient suspicion of this wound is or wound or this contamination or there is suspicion of this infection, it's better to go to the secondary closure. The secondary closure that will be allowed to heal with the formation of the granulation tissue. This method usually prefer when that's poor wound approximation or contamination or delay in that patient he is present, they are very late. Delayed primary closure, that patient he is just that wound is cleaned and observed for several days, then we can return that patient back to for closure of that area. Closure decision and time of since injury for this patient. Time since this injury is important factor to determine whether it's not a wound can be repaired using the primary. Before, you think in 1973, you think is documented if there's any delay or not delay and or the patient not close in the first 6 hours, we cannot close this one because he think if that infection can increase of chance of that infection and bacterial proliferation for this patient. So, but the recent study have found that's different in infection rate when you wound are close more than 6 hours and after the injury. So if find the recent study, no any difference between the closure of this wound the first 6 hours or after 6 hours. 2012 meta-analysis for study on 3,724 patients found no significant increase of infection rate when wounds were closed by primary closure or with the cut-off period set in the study. So, in the American College of the Emergency Physician, clinical policy for that penetrating injury of that extremities emphasized that decision of that on closure on multifactorial. That's the problem. For some factors can fix that closing or effect of that closure of the wound, like cannot be made because this patient um, clinician should be depending on the age of that patient. What's the age of the patient, wound location, degree of that contamination, and mechanism of the injury. Also, the pre-existing disease, like the patient, he's maybe the patient's ability to adhere to the follow-up care. Also, that's factor in affect that outcome of that closure or that outcome can happen for that closing of that wound. The policy states that the most laceration presenting within the 8 to 12 hours window can be undergo primary wound closure safely. The ideal treatment wound for retain from body removal is within 24 hours of the injury. That allow that visualization of entry and exit of that wound. And as inflammation or induration are and scarring will be not yet have developed, that make difficulty to remove that from body. Closer outpatient follow-up, close outpatient follow-up for that foreign body is that cannot be removed the emergency. It's very necessary and very close appointment for this patient. What about wound irrigation? Wound irrigation is amongst the most important steps in the wound care. Irrigation removal of the fertilized tissue, dirt, bacteria, and very effective to irrigate depend on that volume, pressure, and solution used. All the literature, he found that lower rate of the infection in wound cleansed with the iodine, some compared to that clean with the normal side. But in the last recent study, he shown no difference in the infection rate with the use of iodine or normal saline. What about sterile gloves compared to the septic technique? Systemic review and meta-analysis of 12,275 patients found no difference in the infection rate with the use of the sterile versus non-sterile gloves during the wound closure. Use the sterile gloves is no longer routinely recommended. What about anesthesia? How to make good anesthesia? As to make good topical anesthesia or intradermal anesthesia or nerve block or procedure sedation for this patient. Topical anesthesia is very effective and less painful method for that anesthesia. Maybe many types of that laceration. Reduce the need of that intradermal injection. Equivalent that's or superior to the analgesic efficacy of that topical formulations of that compare with that conventional intradermal infiltration. And found in 1980 study found that the topical solution of tetraquine with the epinephrine and cocaine, this one will be work equally well with the pain control as intradermal anesthesia. Later study, he found that solution 4% of lidocaine and 0.1 epinephrine and 0.5 of tetraquine can be equal to TEC for this patient. One major disadvantage of this topical anesthesia is show that the rate of the onset, which may be that's the main problem. So if the patient with the topical laceration, you can put that local or topical anesthesia from the triage and ask the patient to wait. Then you will be the patient ready for that procedure after past half an hour or 1 hour from that starting that topical anesthesia. Intradermal anesthesia is injectable anesthesia, remain that's mainstay of the treatment due to easiest to use in the time of the restraint in the emergency department. Lidocaine is the most commonly used local anesthesia in the United States today. Epinephrine sometimes can be mixed or added to lidocaine to prolong of action and to reduce the toxicity and provide some degree of the hemostasis and laceration. You know, before there is prohibited or not allow or there is avoiding to use epinephrine in the end or in the digital or in the organ defined. This may be decrease the blood, but the last literature you can use epinephrine now free without any complication with any patient with the local anesthesia as in digital or block. Sorry, in the fingers or make any procedure you can do it with the lidocaine. We can add epinephrine, no problem. Method can be reduce the pain associated with the infiltration, include slowing of that rate of that injection, and injection with that wound will be instead of that through that intact skin, you can just infiltrate it in the wound directly. Warming of the anesthesia and buffering by 1% of the lidocaine with the sodium bicarbonate, sometimes to decrease that pH and maybe decrease that pain associated with the infiltration. What's the dose recommended for the commonly used in the local anesthesia? It's very important to be more familiar how to calculate the dose. It's very important if he's that lidocaine is with the epinephrine or not without epinephrine. It is, if you see this one, lidocaine is you can use to 5 milligram per kg, but you have to be sure about your concentration if you are working with the 1% or 2%, because 1% will give 20 milligram per per each 1 ml. And if you are using the 2 ml, 2%, that's concentration, that's meaning every 1 ml is give 20 milligram. So you have to calculate depending on the weight and don't exceed that maximum weight for this patient. If the patient with the epinephrine, we will give lidocaine, you can give 7 milligram maximum with per kg for this patient. The action usually from 30 to 90 minutes for this patient. Lidocaine for this one, if the patient will use instead of the lidocaine, it can be used 2.5 milligram. If you add epinephrine, you can 3 milligram per kg. الديوريشن 200 النوع البيشن 0.5% concentration usually every 1 ml is 5 milligram. This is very important. There is meta-analysis show for randomized control trial. They found that's insufficient evidence to recommend use of avoidance of the epinephrine in a digital block. Additionally, systemic review of 7 study conclude that use of the lidocaine with the epinephrine is standard commercial concentration for the digital block is not harmful and maybe have some advantage for improvement of hemostasis for this patient. A nerve block for a patient, it can be avoid a large dose of intradermal anesthesia by using digital block. How can this one? This is the whip for this is the finger. You can use that filtrate, and if you want to make digital block for this finger, you can use this dorsal whip for the hand between the finger and just infiltrate in this area and the other area. If you want to use one dose, single dose injection, you can just in the proximal pharynx, that's the creases of that skin, for injection of that the balm. You can in the center, you can use one single dose for this one to make digital block for this patient. Procedure sedation, patients sometimes who require more extensive repair, who are unable to be not cooperative with that closure of the wound, you can go for procedure sedation. Unfortunately, I see that procedure sedation is misused for this one for any case. But I think can be avoid or try to not use as a routine practice for AR to use procedure sedation for a lot of things. And this will make time length of stay of the patient AR will be make problem for visual length, and also can expose the patient that complication can happen from that for that from the using of the sedation. Suture, it is the first step in the suturing is to determine which type of suture to be used, absorbable or non-absorbable. Absorbable suture as made of that synthetic polymers or collagen and is eventually is degraded by an enzyme losing the tensile strength within 60 days. طيب non-absorbable suture are non-biodegradable and maintain their tensile strength for more than 60 days. So can be monofilament materials like nylon or polypropylene and is prepared by for an non-absorbable suture due to that it is strength and relatively low tissue reactivity for this patient. The decision of that use of the specific suture type is often guided by the wound location. So depend what you are suturing. Suture size also is also matters because of that potential for cosmetic injury for this patient. Okay. Now we'll go through that type of suture. Suture simple interrupted suture, continuous running suture, running subcuticular suture, mattress suture, or corners stitch or correction of dog ear. As you know, the simple suture or interrupted suture, this is everyone you know this one. He just patient. He just make this is perpendicular angle for this one, sharp angle or right angle for this one, and just bite the skin and make more deep for one side and crossing uh, uh, and just exit this one in one side on the edge, then again bite to the other side to um, make exit for that needle, and from the other side then you can start your make your notes, and first note will be two loop, then approximated to margin, then after that you can make the second and third, and after that you can cut that stitch. After you have to be make 3 or 4 stitch, depend on that type of suture. Okay. It's very important to be more familiar for that needle holder. It is very important to know this jaw, this is the joint, this is the shank, this jaw insert, and this is the ring, and that's that ratchet. This one is very important to be. This will be keep close and holding the needle, and you have to hold the needle from keep 2/3 and 1/3. Leave this part, and you can hold this one from between the 2/3 and 1/3. You can hold the needle to be easy to manipulate and the suturing of the skin.
This is an example of a simple interrupted suture. Grasp the tissue slightly away from the intended target. Bring the needle in 90 degrees to the skin and rotate the needle through the tissue. Reload the needle. Again, take only the dermis and epidermis and not the underlying fat, and rotate through the tissue to prevent inadvertent tissue damage. Bring the suture through the tissue, leaving a fairly short tail.
So we make a short tail for this one.
Bring your needle driver in parallel to the wound. Loop the suture around the needle driver twice. Grasp the tail and cross your hands for the first part of your surgeon's knot. Bring the needle driver back across, create another loop, and cross your hands to create a square knot.
Okay.
Continue adding throws appropriate to the type of.
So the other type of suture, this continuous running suture, this easy way, because you will not make every stitch will be make knots separately. No, you will this the best used for long linear laceration. It's very rapid, removable is easier, and provide very effective hemostasis for this one, and also distribute the tension evenly along that length of that laceration. Okay, so like this one, see. The first one will be make knots, okay? Then you will not cut this one. You will continue to make other stitch. You'll see. Now we keep this one. You will start again to make other stitch. now. Okay. Till he finish from that type of laceration. Okay. At the end of that continuous running, you will make the last note for him to close that that suture. Make like this one, then this is the last one. Yeah, you keep like this one. You make like loop to be easy for at the last one to make the last notes for him. Okay. The buried stitch, subcuticular stitch, that's usually many patients came to the ER asking about that plastic surgeon. I want that good cosmesis for this patient when later on, and he request plastic surgeon to fix this one. He requests for this reason. He need that this is subcuticular. He needs subcuticular stitch, and you want all that stitch is not, you cannot see that one. No more knots outside. Usually at the dermal epidermal junction and provide additional support for the wound after the skin suture are taken out. Minimize that dead space within that wound to avoid the skin suture mark. He can last bite is taken, make like loop for this one and lift in that suture and make maybe sometimes you can make them like knots for this one, and after remove this one to be easy to remove from the skin. The benefit of this technique is that eliminate of that bite mark made on the percutaneous suture and provide close approximation of the wound edge for this patient.
Right equipment. Start out with properly fitting sterile gloves. Find a pair of straight Mayo scissors, toothed Adson forceps, standard sized needle drivers, and of course, sterile suture. There are multiple ways of starting the subcuticular suture. We'll demonstrate a method commonly used at our institution. We begin with a deep suture near the distal apex of the wound. Starting on the left side, go from deep to superficial, from the dermis to the dermal epidermal junction.
He not exit this one from the skin. It's just between the dermis and epidermis.
Move to the right side and pass the needle from superficial to deep. Tie approximately 4 throws of your needle driver and cut the short end
You
close
make
to God.
very the first knot for the stitch.
Once you cut the short end, reload your needle, pass it under the knot, and come out just at the dermis of the apex, effectively flipping the knot down and burying it.
Now we will start from the beginning, and you will start.
Now we'll start running the subcuticular
Yeah.
suture.
So we start same what he did here, and then you go to
Two
the other
steps on
side.
the right side.
Dermis epidermis.
Everting with the Adsons and passing parallel.
Till he finish. You do it like this. It will show you at the end what he will do. Okay. The last one, see?
Once you've reached the proximal wound edge, you're ready to close the subcuticular. At the apex, take a small bite as you normally would.
Okay.
Instead of pulling the suture through, leave a sizable loop.
You make like a loop for this one. To make the last loop for this one or last knot.
Keep the free end in your dominant hand, and with the other hand, reach through the loop, grab the free end and pull. Pull the loop tight, creating a new loop.
Okay.
With the new loop, repeat the process once more.
Okay. He did the last knot for him. You see, if there's no any knot or any stitch outside.
With your third loop, pass the free needle completely through. As you
Okay. Then you can bury this knot. You keep this outside.
put tension on the suture so the skin puckers slightly. It's now safe to cut the suture flush with the skin. After safely returning your sharp, inspect the wound and apply appropriate.
So mattress stitch is very important as two types, is vertical and horizontal. The mattress horizontal for this one, a needle is passed 0.5 to 1 centimeter away from that wound edge, deeply into the wound, and can be used for a single layer closure of that laceration. Why? For the patient who has tension and needs to make good to overcome that tension on that wound. Horizontal mattress usually suture also used to simple interrupted suture. However, before that tying the knot, another one bites like the simple, taking to on the same side as the suture line and lateral to the exit point and pass to the other side where the knots can be tied and make that knot. So it's you can make one bite, 1.5 and 1 centimeter, then go we have to make good deep bite and you can exit same. Then again you can the same side a lateral from that's that's exit, you can make other bite and then you can make the knots in the other side. It's good for technique for the closing wound with the poor circulation and wound edge.
If I had my choice, I probably would never create or construct a horizontal mattress suture because.
So what he will do, try to approximate this one. This is with the tension.
That's to.
So make this bite.
To the blood supply, to the incision site. However, the horizontal mattress suture has a component of it that actually goes perpendicular to the vessels. And remember, the vessels of which I'm referring here are the vessels that are feeding the incision in this direction here. And so to construct a horizontal mattress suture, we first take a bite on this, the near side of the incision, the far side of the incision.
Okay.
We reverse the needle.
Then you can lateral from this one.
And you can gather the suture. It's likely the proper way to do this, but it's just an extra
make
step.
It more tail for this one.
We're going to then attach the needle for a backhand suture bite and go from the far side of the suture or far side of the incision to the near side.
Okay. Then after that,
and we're ready to tie. Now, of course, it's proper to go ahead and gather the suture. So you can see the horizontal suture now, the horizontal mattress suture is very effective at mitigating tension. Both the vertical and the horizontal mattress sutures are very good at mitigating tension, thus their tension relieving sutures. But notice now that the horizontal mattress suture, once tied, is the limbs of the suture now are perpendicular to the.
So the other type of that mattress that's vertical, it's very helpful for that effort skin. And what we will do, we will do far, this one, far for this patient and near. So you will do what? First, start from this point, will go far from that edge, then go back far from this one, then again go very close to the edge again, then go very close to the edge for this patient.
Next is the vertical mattress suture. Vertical mattress suture is a very useful suture, especially when wounds are hard to close, if they're under a lot of tension, or maybe there's a lot of swelling or you anticipate swelling. It's especially valuable when skin edges want to keep rolling in and you want to evert them. Some will call this the far, far, near, near stitch. And this is the configuration of your suturing. We're going to enter far from the wound, travel under the skin, come out far, and then come back and go near, near. Essentially, you're taking this part of the skin and closing it to this part of the skin, and that's the power of the suture. A simple suture is really relying on a much smaller area. So we'll start far and travel under the skin. And the same thing on the other.
Okay, far, far, then near, near. Then we can make a good effect.
When we tie this down,
Effected for the skin.
is that this approximates and everts the skin edges, and we can make it just as tight as we want. We have our granny knot, that'll hold it. And we'll square our knots.
So other part of that's very important. We have to more familiar. That's have a buried horizontal mattress. That's the corner. If there is like flap, that's what I mentioned the my presentation type of this. You know, some cases like tensile or this present with the type of cut wound can be make like flap. So you have to make half buried. You have to insert that's your stitch, this one, or bite this skin. Then you can make bite from dermis epidermis, but don't exit this one outside of the skin. You just make curve this one and again back dermis epidermis, and also you can also bite the other side. Then you can keep this that flap in the place. That's, you know, that's a flap usually the vascularity is very poor, so and to decrease that vascular compromise can happen for the corner flap.
This video is a demonstration of placement of a corner stitch, more formally known as a half-buried horizontal mattress. This is for V or Y-shaped incisions, stellate incisions.
Okay.
The first step is to go percutaneously through one edge of the tissue. What I typically do is reserve the edges the most flap-like, that comes apart the most, for where I'm going to place the subcuticular layer, which is what's going to happen now. So essentially, we're going to drive this second throw through the dermal layer and out the dermal layer of that flap edge, basically never piercing the epidermis. And that's going to catch the flap edge.
Okay.
From here, what we're going to do is reload our needle driver, and we're going to go back into the third edge of the tissue. This time going from the dermis and then out of the epidermal layer at basically an equal location across the wound from where you first pierced the epidermis.
Then you can make.
And now you're going to tie it off in the usual fashion like you would for a simple interrupted suture, making the knot lie flat. And what this is going to do is help you approximate those edges of the stellate wound, so you can now begin your repair of the laceration.
So other problem we can face if there is, if you make a suture for any wound, and at the end we find like this, like dog ear. What you have this one, you just complete your stitch and keep this one, just make cut at the base of this is fold, okay, and then cut this is the fold, this one, and then you can complete your simple stitch for this one, the interrupt stitch for this one, okay. Like this one, you can see you can make this one. This is like this dog bite. You just make line this one, and just keep that flap in this area, and just adjust this one and cut. That's the more than that's need for closing of that wound, and you can remove it.
On the longer edge of a wound, it cannot be corrected by suturing it under. Instead, you have to lengthen the edge of the wound and then remove the extra tissue. This demonstration uses a skin model to illustrate the correct method for dealing with a dog ear. The wound repair adjacent to the dog ear illustrated is uneven because of the method used to create the dog ear. In clinical practice, the repaired wound adjacent to the dog ear would lie flat. As you can see from the video, the dog ear is raised above the surrounding tissue and will not lie flat. To repair a dog ear defect, you first extend a line out 45 degrees from the wound going towards the side with the dog ear. Once you have marked the skin, you undermine the area beneath the dog ear. Next, using a pair of scissors, you cut along the line to extend the end of the wound. This will leave you with an extra piece of tissue, which you then grasp with forceps and stretch until it lies flat. Then, using scissors again, you cut this extra piece of tissue off using the 45-degree cut you had previously made as a guide. The final step is to suture close the remaining wound. In the final example, the closed wound lies.
Okay. Other modality of that closing of the wound, that's tissue adhesive. Tissue adhesives are made from the liquid. Usually, some parent request that's glue. This is monomers. That's one, or that's polymerized. That's into the stable wound when they are come to the contact. Moisturizing skin. That adhesive lasts approximately 5 to 10 days and gradually will be sloughs off as the new epithelial skin grow. Tissue adhesive is easily used, don't require that anesthesia, and very pleasant and very requested by many of the parents. It's very effective in some wounds if there is no tension in that area. But you have to avoid that area is very close to the eye or the eyelash, which sometimes can make problem or complication. Tissue adhesive is the best for low tension wound with the linear edge. When applying to the adhesive, the wound should be held together on the margin as well, approximated. And if you want to remove it after 4 or 5 days, you can use the petroleum-based product such as antibiotic ointment or petroleum jelly, or can be used for removal of this layer of that adhesive materials. Tissue adhesives have the additional benefit for having some bacteriostatic effect.
Apply Dermabond Advanced on a dry wound. To apply Dermabond Advanced, hold the applicator away from the patient with the tip pointing downward. Squeeze the bulb to crush the ampule inside and then release pressure. Gently squeeze the bulb again to moisten the internal filter with adhesive. Approximate the wound with gloved fingers or forceps. Apply Dermabond Advanced in a single continuous layer, maintaining steady bulb pressure.
Other modality of that used for closing of the wound, that's staples. The staples will be very quick, easy, and be used and can be very cost effective. Staple can be at least precise and should be limited to the use for linear and non-facial laceration. Staple should not be used in the face or neck or hand or feet. Type if you're using or placing the stable stable removal kit to remove if the on hand or so that it can be misfired or misplaced stables can be removed easily by stapler removal and can again you use the stapler to fix it again.
Another remarkably helpful tool to have in the field that can save you a lot of time is a skin stapler. I got this one off the internet for about $7. They're disposable and have about 10 staples in them. Here, this particular pig, we've made a laceration for practice. And in order to close this very quickly and simply, or the stapling end right against the wound and just push down. You can close a wound in no time. Here we're going to show you how to use the skin stapler close up. Line your stapler up with the arrow at the end of the device right in the center of the incision.
You have to keep in the center.
Push down tightly.
The laceration wound, you have to be in the
And
center.
deploy the staple. Do this in about 1 centimeter increments.
And you try to approximate it.
Exact instructions on this are given in the prepper book. Remember, you're going to need a staple removal to get these out softly. If you try to
Other technique you can use that hair position for this one. Hair position, this one you just approximate it in the skull. You can use this one just to hold some part from the one side. You can crossing, this is the laceration after cleaning and irrigation, this one. And after that you can put some glue in that area of, if you crossing one area hair of bundle of hair in one side, the other one in the other side, and you can put some glue for this one to fix in this one. And easily to remove it later on by using some moisturizing or that's any petroleum materials. You can remove that one easily for this one, but don't use for any large one or how there is active bleeding or is not linear. Okay, and or infected this one, so it's not practical. This is side, this other one, you can remove it. This application of adhesive side is simple, painless, and very quick method for laceration repair. These tabs should be not used for that simple that low tension. So you can use it in some cases. This should be placed very particular with the space between that edge of that stitch. So other technique that's treating with the wound with the zip stitch, other technique is very helpful.
Provide the wound and surrounding skin with clean gauze.
You can keep this.
If a zip stitch is used, the skin surrounding the wound must be completely clean and dry in order for the adhesive to stick well. Place zip stitch over wound, pressing the adhesive firmly on both sides of the wound. Gently pinch the wound closed while pulling on the straps.
You approximate it this way.
Don't overclose the wound. Stop when the edges of the wound touch. If you have clean scissors available, then cut the excess straps. Apply a protective dressing over the wound. It is important to prevent dressing adhesive from touching the zip stitch device. Dry the wound.
So there is some special circumstances for this one. Most laceration can be repaired in the emergency by the emergency clinician, but there are several indications for specialist consultation need, and that including wound for joint involvement or neurovascular injury or tendon or muscle injury or retained from body or any amputation or that patient resulting from the last or high pressure injury. So laceration on the eyelid or medial canthus or lip or hand or some intraoral wound maybe can be also require specialist consultation due to that close association between the quality of the closure and subsequent cosmesis and function of that part. Facial laceration, one of that important presentation. Facial laceration can be range from the simple cutaneous laceration to more complex injury such as the ear or eyelid or nose. So patient present to the facial laceration as often present with the concern with the cosmetic outcome. Always the patient and parent request about cosmetic, especially in that private hospital. In small survey for the emergency clinician regarding of the choice of the closure method of the facial laceration, tissue adhesive was the method of that used most commonly in 32% of closure. followed by the suture 30%, and the third most common method we combination of the tissue adhesive with and strips, adhesive strips around 82.6. No needle alternatives such as that combination of the tissue adhesive and adhesive strips can be preferable to suturing facial laceration and decrease the pain, the time and the emergency and follow-up visit. No needle methods are also beneficial to patient who is prone to the keloid or hypertrophic scar formation. The size 5 and 6 suture are recommended for any epidermal suture, especially for the face. Usually repair of the facial laceration within orientation is parallel of the skin tension line, and therefore that's perpendicular to this fiber to facial muscles. And the last result of that cosmetic outcome is good. This one table showing the size of that suture you need to be selected. Depend on what type of you want to suture. If you want to suture for cheek or forehead or nose or skin, you can select from 5 to 6 size for this 6O. Ear skin usually for O. Eyelid skin 6 to 7, frontal 3 to 4, and you will give you some option for you as new and nylon, proline or nylon. You can select depend on that type and select depend on what's preferable that you can use for suturing of that part. An eyelid laceration, one of the challenging us that eyelid structure are delicate and or organized by 5 layers: skin, subcutaneous tissue, and orbicularis, and oculi, and muscle, and tarsal plate, and with conjunctiva. So superficial laceration without involvement of the other list of the layer, you can use by emergency physician, you can close this one by 6 to 7 suture stitch. Tissue adhesive should be avoided in the eyelid. We make a lot of communication can happen. Eyelid laceration that will be accompanied by ptosis or disruption of the lid margin or injury to that lacrimal duct, or involvement of the conjunctiva or tarsal plate. Usually the lid should be promote that consultation or ophthalmologist specialty for this one. Wound within 8 millimeter of the medial canthus should be promote concern for lacrimal duct injury, and so we have to consult ophthalmologist for this patient. And intraoral laceration, small intraoral laceration do not necessarily require repair, but the laceration require proper irrigation for that sense, and inspection for foreign body such as tooth, fragment of the food particles. There is indication for repair if include wound of the length more than 2 centimeters, or presence of tissue flap or interfere with that showing, or there is a laceration large enough to be trap food particles. Similar guidelines should be followed regarding of the tongue laceration. You have to do what he did in the tongue laceration: small laceration, no need to suture, non-gapping wound, and no need for close primarily. Lip laceration is how to start to close it. It's very important that firmulon, that's red portion of the lip, is very important to be closed in the proper way, and because there are 3 anatomical portion of that composed of the lip, that laceration you have to be the laceration that traverse that's the firmulon, or cutting that firmulon border where the skin and that firmulon meet, that's particular concern, as this both this very have a very precision for that repair of that's impact, both that cosmetic that will be affect that function and also the function of that lip. Good anesthesia for upper and lower lip can be achieved by infraorbital and mental nerve block, respectively, and mucosal laceration as that intraoral laceration don't require primarily closure if the laceration is very small. If there is any satisfactory spontaneous approximation of the wound edge, so no need to close it. Through and lip laceration should be repaired in layer, begin with the mucosal layer, and then laceration should be re-irrigated from the skin side, followed by the closure of that orbicularis, aureus, and muscle, and finally skin layer. I will show you, like this one. You start from inside and try to close this one, and make good irrigation. And there is this later you have to keep that muscle, orbicularis, aureus muscle, close to each other. Then you have to close the femoral line, and then interrupted suture, you have to be close it one by one. Cheek laceration, this is also other one important, you have to be more familiar, that's parotid gland and facial nerve. Sometimes required to be special consideration when that's evaluation of the laceration to cheek to the cheek or the face. Uncomplicated laceration of the cheek without any form of deeper structure can be by the emergency physician to close it. Through and through laceration of the cheek should be repaired in layer, like what he did in the lip intraorally, and the cheek laceration should be re-irrigated after the buccal mucosa has been closed, and then the subcutaneous layer of skin can be closed. That's one. Pre and post repair, you have to check if there is facial nerve is intact or not. Thank you.
Thank you very much, Dr. Hamad, for this comprehensive and very interesting daily lectures. Wallahi, I learned even myself from these lectures. I think we have few questions here. What to do if glue get in the eyes?
Good questions. I faced this problem in my field.
Second answer, yeah.
Sorry?
I need 10 seconds answer. Don't, because there is so many questions.
No.
He's waiting.
You can gently, you can use that petroleum materials like antibiotic, that's ointment. You can apply in that area, and gently you can release that adhesive area. Sometimes you can trim that eyelash if he's close to each other. If you failed in the first trial by that petroleum ointment.
And usually irrigation with normal saline. Yani. Okay, another question here, also for you, Dr. Hamad. Question here, in flail chest, is intubation indicated? Yes or no?
No, not as usual. Sometimes it can be used a flail chest if you failed to fix this flail chest or affect that saturation, and we difficult to operate the patient in the time of that presentation. You can intubate the patient if he's desatting.
Operated. Yes, yeah. Agree. You mentioned, and usually we'll treat him like any other patient. If he is desatting and he is become in respiratory failure, of course you have no choice. You have to intubate. So it is indicated in respiratory failure indication or pressure positive ventilation should be considered. طيب, last question, Dr. Hamad. What about tetanus vaccine? Is it indicated for all kind of wounds?
No. It depends what the last vaccine for this patient. How is this patient complete the vaccine or not? If the patient complete vaccine, you just count if the first 5 years, okay, clean or dirty wound, no need vaccine. If after 5 years, if it's a dirty wound, you have to give vaccine. Okay. For that patient, more than 10 years from the last vaccine, no, you have to feed it or clean. For wound, you have to give vaccine. For that patient not vaccinated, you have to give vaccine with the IVIG also.
طيب ممتاز جدا. Thank you very much, Dr. Hamad. We'll stop with this question. And some of you were asking about the schedule. I think the schedule, our coordinator, she is trying to put the schedule. We now left with Dr. Salih al-Shihri. He will give two topics, genitourinary. I think it's there now. This is for today. We finish, and also for tomorrow you will have it on the screen. Today, Dr. Salih al-Shihri, he will talk about genitourinary trauma. This one's supposed to be done tomorrow, but he will do it today. Plus the other lecture, I think, dental trauma. This is like small lectures, and I hope, Dr. Salih, are you around?
Yes, I'm available, Dr. Muhammad.
Yalla, you can start, please.
Okay, just give me a few minutes. I will put the slide now.
طبعا for those who are asking about the lectures, how they can get the lectures, I think our coordinator, she put the link for future vision. Okay, it is all as in YouTube, so you can go there and download it, or you can review it. Okay, and if there is any question, please, you can leave it in question and answer, because we can reach it very quickly. For this one who is asking about dental trauma, you can wait. Dr. Salih will answer your questions soon.
الصوت واضح دكتور محمد؟ Dr. Muhammad, is my sound clear for everyone here?
Your sound is very clear. I will leave now the microphone for you.
طيب، بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا وحبيبنا محمد عليه أفضل الصلاة والتسليم. I'm just going through the genitourinary patients when you present to the pediatric emergency. Let us go start with this case. This is 11-year-old female present with left arm pain after being injured by horse at her right side. So also she had abdominal pain, vomiting after 30 minutes from the incidents. The horse was poked and bumped into her, and she fell to the ground, but wasn't sure whether or not she had been directly kicked by the horse. When she arrived to the triage area, they make her as a CTAS 2 to the emergency because of the trauma. The patient had also at the time gross hematuria. Initial vital signs was slightly tachycardic, blood pressure 106/60, heart rate it was 120, not 90 beats per minute. RR was 20 and was okay. On reveal, she was pale during she was in the putting in the bed. She have some chin abrasion. She has horseshoe shaped contusion over the right side lateral rib from the back, right side. And also she had tenderness at the side of horseshoe shaped. And also she had tenderness in the abdomen from the right upper side, upper quadrant, and right flank. Sorry, I have some flow, that's why my sound is already changed. Bilateral, she had bilateral peripheral intravenous catheter were placed by the emergency physicians and given immediately bolus of normal saline and was administered in the emergency. What are the priorities here in initial evaluation and management of this child? How would we evaluate it for this possible renal injury? Any clue for this? Yeah, always start. Basic is basic. ABC. Yes, that's right. Let us start with ABC, primary and secondary survey. So we'll pass this and we'll go direct to the case. Trauma team had been, actually trauma code was being activated in the emergency because of the type of trauma there, and trauma team was being arrived and evaluated. There's no problems with ABC primary. She been connected to the cardiac monitor and pulse oximeter. Her lab was showing hemoglobin 12.8, hematocrit 38.3. Renal function test was showing urea was 18, and creatinine was 0.7, and urinalysis was showing too many RBC under microscope. So abdominal and pelvic CT with contrast had been done. Patient was stable at the time. So showing grade 3 laceration of the right kidney that extend through the proximal collecting system, showing large perinephritic fluid collections. She did also delay phase CT of the right kidney that showing extravasation from the collecting system of the right upper pole. Interval enlargement of the perinephritic fluid collection and compatible with blood and urine there. The amount of intermediate intensity ascites was slightly increased, but not so that much, and composition with compatible urine. The patient already referred to the PICU for continuing monitoring. Urology had been consulted. He preferred to start conservative treatment. No surgical intervention at that time. The patient was stable. Hematocrit was stable for her. Because of severe concurrent liver laceration, the patient was hospitalized for around 9 days, and she was hemodynamically stable. Serial of hemoglobin, CBC, hematocrit was all normal. So traumatic injury is the leading cause of morbidity and mortality in the pediatric age group, and genitourinary system here is, alhamdulillah, involve only 3 to 5% of all traumatic injuries here. What is the commonest site of genitourinary injury here? The commonest site is kidney, because the kids, the anatomically of the kids is lying in the ribs, and they can have trauma at the site, so it's 63%. Unfortunately, for the commonest site of genitourinary is not much papers for this, only very, very few. Trauma to the external genitalia account for 25% of total genitourinary injury. Bladder urethra account for 9% and ureter 1%. What about mechanism of genitourinary injuries here? MVA is number 1, 46% overall, and for renal trauma account for 66%. Fall from height, and usually from double or triple height, overall 26%, and for renal 28%. Sport related is 4%. Assault 2%, and other only there's we don't have much statistic about this, but for overall is 18%. The commonest trauma for there is iatrogenic urology injuries, especially laparoscopy, bladder's injury, oncology patient. They have retroperitoneal resections, and they have some injury mainly to the ureter. Urologic, ureteroscopy, perforations, avulsions, hemonephrectomy, the vascularizations, ureters reimplant, stricture can cause stricture, hernia repair, which is common surgical intervention there for pediatric, can cause bladder resection, benign inguinal scrotal surgery by using electrocautery injury. How to deal with GU, genitourinary trauma in emergency? First, to assist the patient, دائما نبدا بالhistory, specific what's the mechanisms, especially if fall down, we need to know exactly what's the height. Fall down, is it on the carpet, is it on the hard floor? MVA, car accident, we need to know the locations. What about the speed? if the patient was restrained or not, even what type of safety belt, it was only one around the abdomen from down, because some people, they're using only one restraining for their child from one side belt only, not in the chair. Positioning, condition of other involved, fall from height, it's considered to be significant if it's, as I said, more than double or triple height, more than 1.5 meters on the hard floor. What type of surface? Also, sport activity, we need to know that exactly what happened, what type of sport. What about assault? What was about weapons, caliber? Who's the victim for that involved in the incidents? Iatrogenic, what type of surgical indication and procedures? In history, taking more careful history for the patient, specific to the type of injury of genitourinary here. What's the initial complaint? What about hydration status? Did patient void since injury or not? Is he able to void or not able to void? Also, if he void, what was the urine color here? Does this patient have any pre-existing genitourinary pathology, a previous surgery? Is he having single kidney or not? About physical examination here. What's the primary trauma evaluations? From the visual, we need to report any ecchymosis, abrasion, laceration, blood at meatus, very important to notice that. Palpation, look for the lower rib fractures, flank tenderness. What about penis or testis deformities, swelling, change color, any tender? Sometimes need to do digital rectal exam because there is associated with genitourinary and rectal trauma there. So to notice any blood or any tenderness when you do digital rectal exam. Percussions, also important about costovertebral angle tenderness. They call CVAT, bladder level. About the auscultations here, we need to know about any sound from renal artery, bruit, or any renal injury or leak from the artery. So carefully auscultate both loin area. Evaluations, lab, we don't need for kidney injury, we don't need much blood work for those patients like other injury from the lung or liver. For kidney, we need mainly the CBC and serum electrolyte and urine analysis. And we may need subsequent urine analysis. In renal injury, 90% it happened result from blunt trauma. Because the kidney is placed above the ribs from the back, so easier to have squeezing trauma there. 10% of abdominal trauma involves the kidney. 20% may be having multi-organs, so be careful. That will look to the kidney trauma. They may have multi-organ trauma, especially spleen and liver. The reason for increasing kidney injury with trauma, kidney is large, proportional to the body of the baby. It's decrease in perinephritic fat, not like the adult, and also thin abdominal wall musculature. Be careful here at this point. Hematuria is not always there with severe renal injury. Hematuria and hypotension, especially at we starting the trauma code, is not always there in renal trauma. So just we need also to take more history if there is passing blood at the site of trauma from the family, and also any associated injury, it is critical. Pre-existing renal abnormality commonly found during the workup of renal trauma. Some of the, if there is 3 to 5%, we've found abnormal kidney, but not been discovered, like hydronephrosis, renal mass, single kidney. Single kidney also one of the commonest found in the trauma, can be discovered during the trauma. Ectopic kidney. It had been present in 20% of renal injury found incidentally. There, the child was completely healthy before. Variation mechanism and findings. Major trauma may be present with no hematuria, especially if the deceleration injury, it caused UBG disruptions, renal artery, ultimate tear, and occlusion. And the minor trauma may be present with gross hematuria. It's not necessary to have major trauma to have gross hematuria. The patient have pre-existing genital abnormality pathology or uretero-pelvic junction obstruction or renal mass. So the question here, when we imaging after trauma, it's unlike the adult. Hematuria and renal injury here are poorly sensitive for renal insult with pediatric age. Up to 2/3 of children with grade 2 and 3 renal injury have normal urine analysis. So we need to consider this one. Not always we have abnormal urine with, with kidney injury. Hypotension and vital signs can be stable, but we need to stabilize the patient, monitor it in the rhesus area for the patient. When we do imaging for this patient, actually all penetrating trauma, we need to do image. Blunt trauma here, if there is deceleration, high velocity, fall from double height, triple height, or more than 2.5 meters. I would recommend 2 meters. Fall down, struck with object like ball, helmet, other injuries associated patient like with significant fracture, bruise of torso, peritonitis. If the patient have gross hematuria, this is one of the indication to do image. Microhematuria, I would consider it any microscopic hematuria after trauma, abdominal trauma, and any type of microscopic hematuria will do image. Better signs instability. How about fast exam here in the renal? You know, انتوا تعرفوا كلكم الفاست اكزام اصبح الامبورتنس حقته في الامرجنسي قاعده تزيد مع الوقت. ف it's first line of imaging specificity here 95%, but a sensitivity حقتها not so that much is 22 to 85%. يمكن دكتور حمد لا يزعل علينا الحين بس it's actually it's high sensitive. It's because it depends on the expert who using the ultrasound. May increase with a serial abdominal exam. Normal serial physical and fast exam within 24 hours essential to rule out any significant renal or intra-abdominal injury. طيب, a CT for renal injury, what's indication? A CT actually, it's one of the best method to stage what renal trauma injury there from out of 5 classification. It can show the arterial, venous, and delay phases, appropriate stages, degree of renal injury. We usually use delayed images. It take time for CT to have a good result and show good picture of all for renal and ureter injury. Also ميزة الCT برضو إنه it can identify other intra-abdominal injury. لكن عندنا مشكلة هنا, we have a problem with unstable patient. Unstable patient لازم كل شيء يكون سريع. we consider single phase CT, one shot IVP. الQB تاخد تقريبا 10 to 15 minutes after injection. Often suboptimal image. Once the patient is stable, we need to do delay image later on. طيب, الرينال injury scale هذه يمكن important لليورولوجيست والراديولوجيست to identify what stage we have it here. And also with the intensivist when we admit to the intensive care. Grade 1, it's only contusion. Patient can have microscopic or maybe have gross hematuria, having normal vital signs, normal result of lab. Also hematoma, about subcapsular hematoma, mild, non-expanding without parenchymal laceration. عندنا grade 2 الهيماتوما, it's been non-expandable parenchymal hematoma confined to the renal retroperitoneal. It can happen. يمكن يكون عنده laceration بسيطة less than 1 centimeter parenchymal laceration but no urinary extravasation لأن لا زالت في البلفيك area ما وصلنا لها. Grade 3 laceration more than 1 centimeter. Here البرانكايمال still we don't have urinary extravasation. A laceration here we have laceration extend to the collecting system with maybe have urinary extravasation here. هنا يبدأ اليورين يطلع من الكدني. يبدأ من stage 3. Stage 4 vascular here being affected main renal artery or vein injury with contained hematoma. الجريد 5 here laceration للأسف هيكون عندنا shattered kidney multiple lacerations كل laceration minimum having more than 1 centimeter يعني يكون عندك multiple laceration واحدة منها يكون أو أكثر يكون more than 1 centimeter with defetalized fragment. طبعا حيكون عندنا urinary extravasations طلعت برا either intra-abdominal or intra-peritoneal or extra-peritoneal. Just simple diagram here for stages. Stage هذه normal kidney. Stage 1 having simple subcapsular hematoma confined to the peritoneal area. يعني just simple to be seen here and confined to this area. الحمد لله البلفيك البرانكايمال الارتري والفين is intact. حنبدا هنا في stage 2 حنبدا في اللaceration it's less than 1 centimeter here. Subcapsular hematoma a little bit extended than capsular area. Grade 3 here we have laceration more than 1 centimeter here, maybe 1 or 2, and extended subcapsular hematoma. But alhamdulillah still we affect the pelvic area والartery والvein still intact. Grade 4 we have here deep lacerations more than 1 centimeter, 1 or 2. It's extend to the pelvic area. Here we may see confined urine outside the kidney, but still the vessels here is intact. Grade 5, which is the worst grade here, we have multiple here lacerations more than 1 centimeters. It's intruding all the pelvic. وهنا راح نشوف اليورين outside we'll see outside the kidney here can be intraperitoneal حتى يوصل للintraperitoneal here. One thing is important here, we may have vein or arterial tear here. A CT here you can see here simple grade 1 simple hematoma. 2 it's more hematoma here. Here we have extensive laceration of more than 1 centimeter. And here also we have fragment kidney, and we can see also even the urine can be outside the pelvic area. The management of hemodynamically stable patient, it's non-operative. If the patient is stable, observation and bed rest inside the hospital, serial exam, serial voided urine to detect any blood in the urine. Need serial hemoglobin and hematocrit. Here will depend more on the hematocrit to observe any drop in the hemoglobin. If necessary, we'll do transfusions. Re-image if the patient become symptomatic. But most of the time in conservative. And alhamdulillah can be discharged after 1 week from hospital. When to repeat renal image here, the old methods, old protocol is to repeat CT after 3 to 5 days and 3 months post-injury. But now the recent papers advise that not to repeat CT routinely, only repeat it if only there is new or persisting symptoms, if there is vital signs of instability or drop in hematocrit, if there is fever, if there is persistent ileus, worsening flank pain, and persistent hematuria. رول اوف التراساوند يوم ينوتس حتى يمكن ملاحظينها في الجميع يعني انه ما في كلير بروتوكول للالتراساوند مع الابدومينال تروما وسبيشالي ذا رينال انجري. ما في بيبرز واضحه كثير في هاو تو دو ذا بروتوكول. بس انه طبعا اخذ انه we are often utilized before the CT. It's better to have our individuals protocol يعني كل مستشفى they will work their own protocol, collect all the papers necessary for that, and initiate your own protocol and having cross agreement with that. ماني شاطر مرة في الزوم. طيب management of unstable patient هنا بتفرق معنا على unstable patient. If hemodynamically unstable, here we need to call the interventionalist. Usually the patient will be stay in ICU, حيطلع من ال ER حيروح ال ICU. بنحتاج ال angiographic or immobilizations to detect any leak from the artery or vein. We required proper imaging, isolated renal injury, no other indication for immediate exploratory laparotomy. أنا لاحظت فعلا في كذا paper إنه they are always try to avoid اللابروتومي والexploratory laparotomy مع renal injury. rehab or renarrhophy أو rehabbing the kidney, partial nephrectomy. عادة إذا وصلنا للexploratory لاحظت إنه برضه في البيبرز إنه most of the time they will end by nephrectomy. Expanding or pulsatile retroperitoneal hematoma during laparotomy, penetrating trauma. It will be considered for high-grade renal injury, يعني 4 or 5, with associated colonic duodenum or pancreatic injury. If there is a renal artery injury, only attempt to repair. يعني عادة بيشيلوا الكدني، عادة حيكون في نفركتومي هنا. ما عدا في حالة إنه كان عنده solitary kidney, they will try to repair it, or bilateral renal artery injury. مع stable patient طبعا. They will do vascular repair or revascularizations, وهذا rare use وعادة successful rate حقتها is not so that high. في شيء اسمه delay hemorrhage from kidney. Initially when he present to the emergency ما يكون في hemorrhage, significant hemorrhage from renal artery or renal vein. لكن being noticed إنه في 25% with grade 3 and 4 renal injury, they may have persistent or delay bleed. والمشكلة كانت happen after 2 weeks. Typically happened between 5 to 14 days after injury. وفي some instances happened after 1 month from trauma. It can happen with blunt or penetrating injury. Patient they prone to have AV fistula, pseudoaneurysm. Ultrasound here is good screening tool. If you notice there is a dropping في hemoglobins after 1 month from trauma, or the patient looks unstable, tachycardic, hypotensive, ultrasound is a good screen. بس طبعا definitive for that is angiograph and embolizations. It's around 80% and can detect accurately the delay hemorrhage. فنحط في الاعتبار موضوع إنه patient can be discharged after conservative treatment to home and may be present with hypotensive. Sometimes they have normal no hematuria or microscopic hematuria, but there is some hemorrhage from renal arteries. So consider me having some delay, what you call delay hemorrhage. طيب في حاجة اسمها urinomas, which is presented urine outside the pelvic area of the kidney and urine leak. Most of post-traumatic urinoma are asymptomatic. 85% spontaneously resolve by itself ويصير healing للبلفيك. الكلاسيك تراياد حقت اليورين ليك واليورونوما اللي هو present urine outside the kidney, flank pain, ileus, and low grade temperature. If you have any suspicious, we need to obtain more image, contrast, CT. The best is contrast, CT with contrast. Retrograde biogram is mandatory if there is concern for urethral injury, and CT imaging cannot identify the ureters. Cystoscopy, retrograde, and stenting typically treat more than 90% of symptomatic urinomas. So pediatric kidney trauma here, 85%, alhamdulillah, can be managed conservatively with no interventions, no exploratory laparotomy. 5% they will end unfortunately by nephrectomy, لكن لاحظنا انه اغلب النفركتومي تحدث لما المريض بيتنوم في الادلت سنتر not pediatric center. 61% is undergoing surgery, more nephrectomy. في الغالب اكثر من النصف اذا راحوا للsurgical intervention they will remove the kidney. Most of the injured children are not treated at pediatric trauma. rate of nephrectomy is 3 times more likely at adult versus pediatric center. حاول تحط طفل تحوله على pediatric trauma center. Organ preservations may be higher at pediatric center trauma. Further study here we need to do about this and why the adult they're removing kidney more than the pediatric. Is it because of they have more referral of pediatric to them? We don't know. We need more research about this. Case 2, here 8-year-old male, he fell striking right side on the wooden bar, having acute abdominal pain, but alhamdulillah, no loss of consciousness. And the emergency, vital signs stable, hematocrit 37%. He's having passing urine with blood color staining in the urine, hematuria. A CT here showed renal injury. Patient had been transferred to trauma center. You have severe abdominal pain. The abdominal tenderness and distended. Hematocrit dropped to 32%, and you're having gross hematuria. And here is showing kidney here. The subcapsular hematoma also involve renal injury, lacerations more than 1 centimeters. So consider as grade 3 or 4 renal injury. We did the cystograms. They found extra vasations of urine outside the pelvic area. So the patient had been diagnosed as isolated. Oops. So the patient had been diagnosed as isolated renal injury, hemodynamically stable, non-operative management, bed rest in ICU, IV hydration need during the staying in hospital, urethral catheter, bladder decompressions, serial hematocrit every 4 to 6 hours. Day 3, transfer to the ward. Hematocrit was sitting at 22%. Day 10 was 22, and hematuria was resolved. Yes, I think adult trauma, they are more expert maybe because they maybe expose more patient there, and their classification may be different than pediatric. Renal injury, this is case 3, 8-year-old boy, fall on the right flank while skateboarding, severe abdominal pain, abdominal tenderness. He having history of appendectomy 3 months back, vital signs. So what that mean? Appendectomy, having some intra abdominal procedures, which is one of the risks for renal injury and ureter injury. Vital signs stable, hematocrit 37%. You have plus microscopic hematuria. Fast done and showing free fluid identified around the right kidney. Here is the kidney shore here, and lacerations, deep lacerations here. So the patient have delayed bleeding, urinary infections, abscess and sepsis, and urinary fistula. This is one of the sequences of renal trauma. Long-term, patient have arteriovenous fistula, renal artery aneurysms. There is some percentage, I think around 20%, with severe renal trauma. They may develop hypertension within 3 years, not immediately, within 3 years. Ultrasound, CT, and MRI for reassessment and evaluation later on with the follow-up. Medical management, angiographic, nephrectomy in less than 20% functioning of the kidney. Need to remove the kidney to avoid the hypertension with patient. Solitary kidney. What about solitary kidney? The patient who present with renal trauma and having single kidney. There is some recommendations actually about those patient, adult or pediatric, كلهم سواء, who been discovered as having solitary kidney. There is so many advice for them to avoid any accident, biking accident, dirty bike, هذول اللي بيجرون في الجبال والhiking, because the vast majority of renal injury happened because of this trauma. avoid intense sport اللي فيها زي الامريكان فوتبول، اللي فيها مصادمات، البوكسينج، الاشياء هذه. For normal function solitary kidney in normal anatomical location, you need to contact a sport medicine for follow up there. Which sport will be fit with you as you having single kidney؟ اللي عندهم بس كدني واحدة، الأفضل إنه يراجع مع sport medicine so they get their advice. What's the proper additional protective equipment also? Avoid motor cross, dirty bike activities. تريبولين، حتى التريبولين اللي هذه try to avoid it. seat belt always seat belt الدبل الابدومين والشولدر. اذا كان طفل restrain في proper car seat at the all time. هذا ما عنده لسنجل كدني هذا. What about ureter trauma? It's uncommon from external trauma. غالبية اليوريتر trauma because of the iatrogenic procedures intra-abdomen. 2% of all ureteroscopy in prepubertal patients, they having some ureter injury, typically managed successfully by endoscopically. Other iatrogenic injury like hernia repair, also testes or capexy. Sometimes على فكرة حتى الابندكتومي برضو they can have some iatrogenic injury. Repair dependent upon the timing of identification of injury, delay or primary open repair typically performed here well. What about bladder? Bladder injury. Pediatric bladder ruptures as compared to adult, children have more intraperitoneal rupture, 36% with pediatric bladder injury. They having intra-abdominal 57% and extra 7% or both. 2 times more likely to extend through the bladder neck. Appropriate imaging is critical to identify extent of injury. Most of the time they need contrast to identify the site of the injury. 75% of bladder ruptures have pelvic fracture. 75 because of the force of the trauma. 6 to 10% of pelvic fracture, they have bladder rupture. So if you found a patient with pelvic fracture, consider this patient, he may have 10% having a bladder rupture. 90% have associated injury. You know, a bladder rupture is not easily to be traumatizing like this unless force and strong trauma there. Unfortunately, 20% mortality rate. What about bladder injury scale here? Grade 1, you're having hematoma, contusion, intramural hematoma, lacerations, simple lacerations, partial thickness. Grade 2, they're having lacerations, which is extraperitoneal, full thickness, more than 2 centimeters. You have grade 3 laceration, extraperitoneals, more than 2 centimeters, or intraperitoneal, which is the worst, but alhamdulillah, less than 2 centimeters. Grade 4, you have lacerations, intraperitoneal, more than 2 centimeters. Grade 5 laceration is extensive of intra and extraperitoneal laceration into the bladder's neck or trigons. هنا اليورين to diagram, simple diagram. Here in the extraperitoneal, confined to extraperitoneal rupture of urine. But here severe trauma that causing intraperitoneal urine leak. لما نشوفها في الاكس راي هنا هذه السيستوجرام ريتروجريد هنشوف هنا extra peritoneal urine leak here blood ruptures. هنا لا العكس، هنا لما سوينا الجراف you having intraperitoneal bladder، هنا اليورين دخل في البريتونيال area هنا. Imaging for bladder injury, CT cystogram or fluorocystogram, having gross hematuria and pelvic fractures, inability to void, and penetrating trauma. All this indication to do CT cystogram or fluoroscopy. Usually add 60 cc to bladder at birth and add 30 cc لكل سنة. يعني عمره سنتين فأنت 60 plus 30 صار 90. عمره 3 سنوات 60 plus 60 120 سي سي. الماكسيمم اللي هو الادلت contrast is 300 سي سي. Intervention. The extraperitoneal injury, catheter drain and antibiotic. طبعا careful, need to be expert when you insert the catheter. Complex extraperitoneal injury here, bladder neck معناته injury have any concern foreign body or bone fragment from the pelvic inside the bladders or the extraperitoneal there. This one need to be explored. All intraperitoneal injury here need to be open explorations and repair. What about urethral injury? Urethral injury also here 5 scale. Grade 1 contusions, that's meaning blood accumulating normal and retrograde urethrogram normal. A stretch of the urethral here, urethral elongation, but no extravasations, يعني still intact, بس إنها stretch. Grade 3 disruptions partial, extravasations on a retrograde urethrogram at injury with contrast visualizing in the bladder and outside the bladder. 4 as meaning disruption complete of the urethra, extravasations on retrograde urethrogram at injury with contrast, not visualized and bladder less than 2 cm urethral separations. أما بالنسبة ل5 فهذا disruption complete, it's more than 2 cm urethral separations عن بعضهم or extension into the prostate or vagina. What about pediatric urethral injuries here? As compared to the adult, it's complete posterior urethral disruptions, more common in boys than old man. لأن short عندهم urethral أو more fragile. Concurrent bladder and urethral injury, it happened in 20%. Pelvic fractures are 4 times more likely to have urethral injury in pre-pubertal girl than women. فلذلك دائما we'll keep in mind any pelvic injuries, especially in the girls, we'll keep in mind that urethral injury can happen there. And bladder also. 5% of pelvic fracture have urethral injury. Increased complexity of pelvic fractures, it means increased risk of urethral injury. There's also the fracture of rami and separation of urethral symphysis. It can also associate with high rate of urethral injury. 15% of urethral injury here have concomitant with rectal injury, and this is very important. Once we suspected urethral, we need to do rectal exam. By the way, all the time with abdominal trauma, we need to do rectal injury as a part of our examinations there. What about female urethral injury here? Urethral, because they're having short urethral here, urethral and bladder, neck, and vaginal injury maybe go unnoticed. ما حد can be discovered initially unless actively investigated, unfortunately, because they're having short neck, they're having short urethral, so difficult to be discovered, especially in the emergency. It's happened. Vaginal injury is associated with 75% of urethral injury. Rectal injury is associated with 30% of urethral injury. Best to examine here under anesthesia or procedure sedations if patient is stable. You need to do cystourethroskopy or vaginoscopy, optimizing evaluation and minimize additional physical and psychological trauma. And with sedation, we be alert for bone fragment associated with the pelvic fractures. لأنه kids, we cannot examine them without anesthesia. It's very painful procedures, and better to sedate the child and examine them well for this sensitive area. Be alert for bone fragment associated with pelvic fracture. It's caused persistent leak and bladder neck extraperitoneal injury. Initial management, retrograde urethrogram, any suspicious of urethral injury like pelvic fractures, blood at meatus, patient unable to void, appropriate clinical history and gross hematuria. Consider suprapubic tube placement with cystogram, utilize ultrasound and interventions radiology. The biggest advice here, never ever catheterize urethral without visualizing channels and sometimes without doing retrograde cystogram. The management of urethral injury dependent on degree of experience of the urologist. Anterior urethral injury, primary urethroplasty, putting cath there till the complete the healing, suprapubic tube diversions if all the above procedures being failed. Pulpar and posterior urethral injury, it's more difficult here. Immediate realignment with the urethral catheter if possible. Long distraction defect associated with the bladder neck injury, associated with the rectal injury. This is more complicated procedures and need advanced center for this. Avoid extensive cystoscopy. Suprapubic divergence and delay repair. But this all the time, they will stay longer in the hospital. Consider transfer to the high trauma centers for definitive care. Delay primary urethroplasty, initial distraction often reduced in severity. Urethroplasty, because I don't know why it's many times fail with kids. So it be reserved for extensive distraction here, because this one need high center and high expert pediatric urologist to apply this. Endoscopy incisions reserved for very short membranous strictures, and unfortunately, it may the leaks happen again or separation can happen again. All repair require long-term follow-up. As I told you before, it can be having recur or failed. Unfortunately, urethral is something sensitive plus ureter and need very special attention and very high skillful surgeons to do that. What about external genitalia injury? External genitalia injury in male, penile circumcisions injury, either to have some partial injury and sometimes complete amputations, laceration of urethra, testes usually from sports, it can have contusions, hematoma, or fragment of the testes, depend on the trauma there. External genitalia injury, be careful also for kids who's coming with crying or inconsolable crying unexplained by the family. It's not always colicky pain. Sometimes you have hair tourniquet somewhere else, fingers, penile area, penis, somewhere else. Especially the mother, when she like take the baby, she have frequent hair fall downs. So this is one of cases they notice only change in the color. So they pick it up quickly and we went to the operation room to remove the hair tourniquet there. It's one of the most difficult because there is a lot of redundant skin here and skin can be hidden inside it. وصعب انك to be discovered. So carefully exams to take the hair tourniquet, especially in the penile area. So we need to avoid any ischemia or لا قدر الله complete amputations because of the hair tourniquet. As I mentioned, always constable crying not always being explained by colicky pain. Colicky pain usually is by exclusion after we exclude everything. What about genitalia in female? Most of the time we present to the emergency because of fall down, trauma, labral abrasions and lacerations. Many times the family will consider about the hymen intact. We need to consider, especially the hymen there is not intact, we need to consider sexual abuse there and need to be reserved the patient for admissions and to be investigated carefully and management. Again, the genitalia, female genitalia examination is not something pleasant and something you like at an emergency because you know privacy and the pain and crying child and the concerns of the family. So better to be examined under anesthesia or sedations. So have better evaluation and minimize additional physical and psychological trauma. We can use a speculum exam, but with highly careful using a speculum exam. Sometimes we need cystourethrogroscopic or vaginoscopic there, as I told you, with highly careful when we examine this area. Last case is 12-year-old male with 2 days history of trauma to the testes when playing football. Now, he having left testicular pain. In examinations, we have a swallowing markedly tender left testicle. Ultrasound here for recommended for all pain tests there. We need to like screening for ultrasound. We need to look to the regular testicular culture, focal area of alter echo texture, which is common with the hematoma or hematocele. Distinct fractures plan in 25%. Accuracy of diagnosis here is good, is 80%. Here is kind of showing the hematoma around the testes here, with some injury fragment here inside the testes here. Testicular disruption, usually because of sport and trauma related, need early, very early surgical within 3 hours of the trauma is the key of potential salvage here. If ultrasound is unclear, operative exploration, there is no CT, no X-ray, no MRI, only between ultrasound and OR. Do ultrasound, unclear, send him immediately for the OR to do operative explorations. Usually operative exploration take around like 15 minutes to explore it, and to close it again, it take around 10 minutes. Unless there is some repair there, it will take longer there. But you know, the exploration of the testis is very short, within less than, I think even faster than tonsillectomy, even though that. So it's very simple to do exploration there. There's some recommendation here a lot, but I cannot read it because the time already gone there. But overall, thanks for all. I'm happy to receive any questions. جزاكم الله خير جميعا. Or any question? Or can I go to the next? جزاكم الله خير جميعا. So can I go to the next عشان التايم؟ طبعا أخذنا 5 minutes more. بس الدنتال والماكسيلوفيشل هتاخذ إن شاء الله شورتر إن شاء الله بإذن الله. طيب, we have some change in our schedule, so we're going to start dental and maxillofacial trauma. This will be part 1. And tomorrow inshallah we'll continue part 2 بحول الله عز وجل. طيب, بسم الله الرحمن الرحيم, والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا وحبيبنا محمد عليه أفضل الصلاة والتسليم. About pediatric dental trauma, it's relatively uncommon compared to the adult. The adult, they have more traumatized life, so they have more sport, more accidents. So relatively, it's uncommon compared to the adult. Incidence increase with age. Male is more than female. Ratio 3:1. The reasons for the dental trauma is different with age. Is non-accidental trauma can be fall even from short distance, even half meter, they can have dental trauma. Motor vehicle crash also, especially if there is not an unrestrained child or not in the car seat. About a fight, especially in the toddlers, school age and toddler, and I mean adolescents. Sporting injuries like footballs, American footballs, whatever. Gunshot wounds being noticed, especially in the United States or many sites in the world. About pediatric dental and maxillofacial. Pediatric, they are young with large head, so they can fall easily, especially when during start to be walk, so they can fall to the floor easily. Craniofacial skeleton here is different. They have poorly developed sinuses there, so البروتكشن حقتهم getting less, more spongy bone, so more elasticity, more adipose tissue in the face, and they can cause more protective for them, subhanAllah. Concerns for future growth, and they can prone to the growth retardations in the maxillofacial or the face. Uh, 68.9% male, the trauma after the first year. Associated injuries more than 50%. They have serious associated trauma. They have neurologically brain injury, cervical spine injury. They have some ophthalmologics problems, eye global ruptures, maybe cardiac and respiratory. About the initial management in the emergency here, overall, the maxillofacial trauma here, the airway compromise, we need to go with the ABC, زي ما قلنا أول, ABC compromise, look for bleeding, obstructive of the airway, loss of skeletal support, swelling, unconsciousness, record the GCS there. Very important here to, as a part of ATLS and pulse pathway, if the child cannot maintain the airway, we need to insert orotracheal intubation immediately and avoid nasotracheal because we cannot roll basal skull fracture here. We can use also difficult airway, you go to the surgical airway. We need to consider also other injury of C-spines, head injury here. Often more comfortable sitting because of the blood and secretions. Important things here, we need to use jaw thrust, maintaining the C-spine, don't move it, don't mobilize it. We need 2 person here to maintaining the airway. Frequent suction also for the secretion there and tooth displacements. Initial management here, overall maxillofacial trauma here, to know from parents or accompanies the child about the mechanisms, visions, changes, anomalous, loss of consciousness happened, abnormal movement, seizures, any pain, where is the pain? Pain with opening and closing the mouth, important here. Inspections here, look to any swelling of the face, lacerations, bruising, movement. We need to palpate all the face, not only where is the pain. We need to palpate all the face. Look to the deformity, look for crypts. Crypts meaning already there is sinus injury there or wound there. Be careful here about what you call this area, medial 1/3 of eyelid, because this will shut the lacrimal gland duct here. Also, look for the upper lip here, upper lip, what's called tragus of the upper lip, because it's initiated here the facial nerve and extensively here the parotid gland there. Physical exams here, we need also to notice the pupils, both sides, about the shape, reactivities. Is it rounded? There looks teardrops there. Look for hyphemia in the eye, proptosis, retracted lids. Look to the extraocular movement. If do you see double visions or normally? Document the acuity, vision acuity. Unfortunately, most of us, we are not documenting the vision acuity there. The Immediate bruising, that meaning immediate trauma there. Raccoon eye is something late to be finding there. And this is one of the serious complications of basal skull fracture. Don't forget, we will not need to forget the ear examinations. Look for hemotympanum associated with the basilar skull fractures. Total signs may not be immediate. Tympanic membrane ruptures, any blood there in the ear. Something important here from the nose, because skull fracture here sometimes associated with CSF leak. So we need to palpate the midface, intraoral palpation for the arch, open the mouth and examine the mouth from inside, check for the movement. Nose, look for any CSF rhinorrhea, which is something like a butter or smelling like butter and clear fluid. If there is discharge from the nose with suspected CSF and looks like blood there, bring the slide and look for double ring. The double ring is pathognomonic for CSF with blood. Looks also like here in septal hematoma, which is something, if we didn't recognize it earlier here, we end up by septal ischemia and deformity, nasal deformity here. We need to observe for jaw movement, trismus, malocclusion, look to the dental alignment with the mouth. If there is any difficulty or pain with the movement of the mouth. Any question right now? هتبدأ سؤال هنا. Palpate entire mandible, each tooth. Push laterally and medially of the mandible just to make sure it's in the place. There is no dislocated or fracture. Fee test have a tongue depressor here. Tongue depressor, tongue blade test. You will put it in the mouth and ask the patient to bite it. And then you need to do twisting. Twist the tongue depressor here. Any pain in the throat, in the mandible area, or in the temporomandibular joint, this is highly sensitive for fracture there. It's simple test. You just put the tongue depressor, ask the patient to bite the tongue depressor, and twist it. If there is severe pain, this is most likely having fracture there. Mandible fractures, also look for temporomandibular joint dislocation and reduction, nasal fracture, and dental trauma. This we'll speak about it now. Mandible fracture here, where is the location of the fractures? It depends on the mechanism here. Is it in the ramus? Is it in the body there? Most common because of the fall down or car accident. It can be happen mainly in kids. They are prone to have condylar process fracture here in this area, can be prone easily to be fractured. If the body of the mandible fracture, that's meaning bad trauma or forceful trauma there that really broken the whole mandible. Mandible is strong, but if there is fracture there, that's meaning we have very bad trauma there. Pediatric patient here, they're prone to have condylar fracture here first, then symphysis, then angle of ramus. Condyles and the pediatric are most vulnerable. This condylar process, they're more vulnerable to have a fracture there. Look for anomalous, seriously, for anomalous in the lip and chin to make sure there is no involvement to the nerve there. The mental foramen here at the site for the inferior alveolar nerve here, it can be affected. If there is any trauma there or in the body of the mandible, the patient will have anesthesia. They're having numbness at that area, and sometimes there is no pain there. What about the image of mandible fractures? Rarely to have regular X-ray because it will not show a lot of benefit from that one. But we can go to the facial film, town view, to see the condyles and the body of the mandible. Panorama, this can happen only by the dentist in their clinic. But this can not detect all type of fracture, especially the condylar areas, because this hidden area there. CT facial film is usually what we did in the emergency CT. And the 3D reformed pictures, it can show easily all the fracture there in the body or the neck of the mandible. What about the treatment? We have some old treatment and recent treatment, but most of the time we are using close reduction by this methods here. Make sure about when you're having mandible fracture, we make sure about the ABC, primary and secondary surveys, okay? They need good analgesia to tolerate to the pain because it's very painful. For open fracture, consider antibiotic, all the fracture there in the face. Because the infection there is very, very serious. Children may have rapid healing, treated within 3 to 5 days, immobilized for 3 to 4 weeks. Close reduction can be sufficient here, inshallah. Should be directed by a specialist and need to be followed up with maxillofacial. They need to have regular follow-up there. Unilateral condyle fracture, they having pain control and soft diet. Unfortunately, for the first 2 or 3 weeks, patient need to be on soft diet. Complications here, growth retardation, growth disturbance, facial asymmetry, malocclusions, ankylosing, inability to open fully the jaw, tooth damage, temporomandibular joint syndromes, salivation disorders, obstructive sleep apnea. They can have dry mouth, they have chronic pain. One of the most serious for this is obstructive sleep apnea. What about temporomandibular joint dislocations and reduction there? This may be sometimes after extremely open the mouth, singing, whatever, shouting, and sometimes with trauma when he having open mouth and he fall down or stuck to the wall or somebody punch his jaw. It's less common because of trauma. Stretch the ligament muscle here. The muscle will be very stretching here at the maximum here, and there will be spasm, and it's difficult to control and close the mouth again. The patient, they cannot close the mouth and excessive salivations. We may need to consider image because of having condylar fractures here. So we need to rule it out sometimes, especially if the first time. Some patients, they have some laxity of the ligament, so they are prone frequently to dislocation there. So if they are chronic, no need to do X-ray regularly. We need to rule out all the time, either acute or chronic patient, to rule out fracture there. You may need sometimes to sedate the patient to close the mouth here. Be careful about your finger because sometimes when you relocate it immediately, they will bite immediately your finger, and this is unpleasant. يعني بينتقل الألم من المريض إليك. أنك ما أخذت carefully وأنت تسوي له relocate. Especially you're using the wisdom teeth sometimes. So this is very, very painful if you're not careful about relocate the temporomandibular joint. Avoid the reduction. You may need sedation, sometimes no need. Many times we need to do using painkiller for the patient. The good with sedation, the patient will be muscle relaxant. They will have muscle relaxant. So it's we can easily to be relocated. We reduce it from front or behind of the patient, depend of the patient. First, we are pushing it down, تضغط على تحت وبعدين تسوي relocate down and backward sometimes to initiate the relocation successfully. OMF all the time, we need to have follow-up for this, for any associated ligament or bone injury there. Consider soft cervical collar for comfort there and support. Use soft diet. Non-steroidal good here. البروفين, الفورتارين, الأشياء هذه is good to tolerate the pain and for the pain. الwarm compression also good for tolerate the pain وبرضه عشان accelerate muscle healing there. الله أكبر الله أكبر. Nasal trauma here. Nasal trauma can happen from any trauma to the nose, fall, sport, bikes, car accident, assault, child who using boxing, football, whatever. The main concerns here with nasal trauma here is having bleeding, fractured breast, organistic fracture, and septal hematoma between the cartilage and overlying mucopericardial. Symptoms including worsening nasal obstruction, pain, rhinorrhea, fever. If not looked to this one carefully in the emergency, we can miss it. Pressure-induced avascular nephrosis and nasal deformity. كل الناس هيقرب عليه. Irreversible if being detected laterally from 3 to 4 days if not treated. This hematoma, septal hematoma, it can be also prone to the bad infection. And the infection here in this area is very, very bad all the time. He needs to be drained in OR and use IV antibiotics if there is infection in this site. About nasal trauma evaluations, we need to do local pressures to stop the bleeding, vasoconstriction agent. We can use phenylephrine or pseudoephedrine, decrease swelling and bleeding and eyes for the evaluations. الفينالفرين أنا ما أدري أحيانا ما هو متوفر عندنا هنا بس it's good to decongest the area. Nasal speculum for better exam, swelling deviations, lacerations. Look for associated injury here. الإكس راي ملاحظ إنه دائما تطلب في الإمرجنسي وهي عادة very 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 rare to request it. So it's not routinely to be done there. لأنه most of the nose is cartilage component and even there is some dissociated or something, only conservative treatment. Nothing to be done, even in the clinic of ENT. CT indication if the flattening of the dorsum of the nose or concern for mid-face fracture there. As I told you, most of the time, nasal trauma, it involves the cartilage. Cartilage, it will heal by itself, need only conservative treatment. So the indication for X-ray is very, very, very rare. We have nasal trauma here, management either asymptomatic, need to be ENT evaluation within 1 or 2 days. Look for the edema resolution. Better, we always ask the parents or the father or mother to take a picture, bring photo of the child for comparison, reduce within 7 days. Symptomatic, marked swelling, deviation, hematoma and abscess. Hematoma reduction by the OMF or by the ENT. Antibiotic broad spectrum here we need to be started. About dental trauma. Dental trauma here, we know, most of us, we know the anatomy of the dental. Here we have the central incisors, we have the lateral incisors, we have canines, we have premolar here. Premolar usually happened with the permanent tooth, not in the primary tooth. We have also the molar, 2 molar, which is something which can be seen in the primary tooth, but it will be add 1 extra after we having the permanent tooth, because usually the primary tooth we have 2, but لما بعد الادolescence وبعد ما يصير عندها primary tooth هتصير 3 هذه. الويسدوم ما بنشوفها قبل 18 سنة تقريبا. طيب ايش الكلاسيفيكيشن عادة الدنت اللي بيحب يستخدمها او حنا بنحب انه to use it to identify where is the trauma area. For primary tooth is different than permanent teeth. Primary teeth here, it's you know that the central incisors first to be erupt within 4 to 8 months, sometimes after 1 year حتى. All 20 of primary teeth in the 3, it will be completed by 3 years. It will be 5 per quadrant. النيمينج هنا important. هيستخدمون الدنتال هنا for primary tooth اللي هو letter from A to T clockwise. شايفين؟ فالletter from A to T start from the right upper corner A, B, C, D, E, F, G, H, I, G, K, L, M, N, O, P, Q, R, S, T here. If missing or complete erupted, use the name, not the letter. So إذا كان في إصابة نستخدم اللتر. إذا كان في missed or something عادة the dental they like when we refer the case to use it by the name. Permanent teeth is different here, not letter. They will use the number. It will be begin to erupt 5 to 6 years. 28 erupted by the adolescents, all but wisdom teeth will be later on. 32 in adult with wisdoms. Sorry, it's from 1 to 32. A number starts from the right upper quadrant, is not 17, 1. 1, 2, 3, 4, 5, 6, 7, 8, until you have 32. Dental anatomy here is important to know about that. We are speaking about that. When you go to the inside the structure of the tooth by itself, enamel, dental, الانيمال هي الوايت الفيزيبل tooth, the hardest substance of tooth. عادة ما يصير لها generation. If you lose it, it will not be regenerated again. It's very hard. It's like stony hard. This one, very, very hard, this one. Then go to the yellowish color, which is the dentin, which is the majority of the tooth. It's less hard than enamel, and it's having microporous structures and surrounding bulb. And sometimes it bleed if you reach to the dental area. Central bulb وهذا هو روح السن أو الdental, which is including all the neurovascular area here. If it's been affected, maybe all the dental here will die. So the central bulb here is containing neurovascular and sensation there. We have another anatomy there from outside based on the gingival area here. The crown area, which is visible portion above the gingiva, it's covered by the enema and including the neck here. A root أو جذر السن is below the gingival line. It's including all the ligament and alveolar bone, root cementum here. وفي عندنا برضو البريدونتال subunits here, which is hold the tooth in place. اللي هي المنطقة هذه. Dental emergency here. What happened if the patient came with dental trauma here? What you will do? Is going to refer it all to the OMF or dental clinic or no? Any answer for this? طيب. Dental emergency here. Trauma 51%. Most involved teeth 88%. Maxillary incisors involved in 86%. Maxillary here. Not the mandible. Above 86 of the cases involving the maxillary incisors here. Soft tissue injury here, intra or extraoral. Bone injuries in 4%. Mandible fractures most common. Caries infections and complications is 40% for dental emergency. Other can have 19. Admission rate is less than 1%. Dental trauma here, epidemiology is difficult. Minor injuries, fractures are underreported. We don't have a lot of research for this. We don't have a lot of papers regarding the epidemiology of dental area. يعني تخيل إنه 30% of reported cases from the single study there. Some estimates suggest for 50% of children sustained dental injury. Preschool age equal male and female, but after school age, male more than female in dental injury. Dental trauma here history is timing important in the first hour. Teeth, is it found or not found? Pain area and tooth, where is it? Jaw motion is important to examine the jaw motion here is intact. Teeth meeting normally. Aspiration risk, loss of consciousness. Primary or secondary tooth. Primary small root and crown. Secondary tooth, longer, wider root and crown. Does the patient have any recent dental work? Any bleeding, having any hemophilia or platelet issues there? Important to take it from the history. Is the patient using any pain medications? What about the immunization status? Because the tetanus immunization here is important and consider it with dental trauma. What about the dental trauma approach in emergency? Identify all fragments and the mandible teeth there. You need to start pain management immediately. Managed by sometimes we need to make a block because sometimes morphine or morphine sometimes is not enough. Avoid topical on fractured teeth. يعني حاول التوث الفركشر tooth, don't touch it because sterile abscess here, sterile abscess and soft tissue is being irritated here. Tetanus, as we mentioned it before, as indicated for the case. About the dental trauma and emergency here, what about images here? Often not need imaging in emergency frequently, sometimes misguide or we not do it appropriately, and especially when you're doing regular X-ray is not so that helpful. Radiographic if suspicions of intrusions, tooth fragment or aspirations. In panorama X-rays, which has been done in the dental clinic, sometimes not always helpful because sometimes we can miss overriding anterior synthysis fracture here. Town's view helpful here and good for the condylus fracture here, for the town and open mouth. CT for facial or condylar fracture is very sensitive. It's excellent for reconstructions imaging here. Crown fracture here, it's usually depend on the Ellis classifications, either to be uncomplicated, so broken only animal or animal and dentin only, or complicated that reach to the pulp, and you will sometimes it can kill the whole dental there. Unusual to have primary tooth fractures, but be careful about soft alveolar bone. طيب. Crown fractures, Ellis type 1, uncomplicated, is usually the animal only, the white. It looks like chipped tooth, low risk for pulp necrosis, 0% almost. Doesn't require immediate treatment, not sensitive to the hot, cold, force air, or percussion. Maybe initially when they're broken, but later on they will not have any pain. They will tolerate to that one because you didn't touch the pulp still yet. Got smooth with any emergency board. Dental follow-up is important because they need to reconstruct it or use artificial enema here for the cosmetic issues. LS2 here are still uncomplicated, but here affected the enema and part of the dentin. It's often sensitive to the hot, cold, force air, and percussion. Risk of infection here is there, but not high. Pulp dental ratio higher in younger patient. Higher risk of pulp necrosis is not so that high. It's less than 7%. Dentists need follow-up. This one need follow-up within 2 days. Dentists will seal to prevent the pulp necrosis. هيقفلها. Usually they're using calcium hydroxide, zinc hydroxide, glass ionomers composite, and apply to the dry mouth here to seal the area here. We'll go here to the something complicated here, what we call it crown fractures LS3, class 3, complicated here, the enema, dental, pulp, all being affected here. This dental emergency, pulp necrosis here, it can reach up to 30%. Concern here, the painful. We need to seal to protect the exposed pulp with calcium hydroxide in emergency. Bleeding, soak in the epinephrine or inject lidocaine with epinephrine. So you will minimize the blood there and prolong the analgesia there. Consider antibiotic to avoid any infection in this area, and bulbectomy and extractions can be considered also. Crown fractures here, type 4, complicated. Here, the crown we completely gone and the root here is intact, but can you see it here? Root fracture here, this is something real emergency. It can cause malocclusions, pain, X-ray to confirm the diagnosis and see the root of the tooth. Then we need to refer to the dental for repositions and splinting. Alveolar bone fracture here, a segment containing supporting one or more teeth is displaced or mobile. Misaligned or mobile teeth can seen by the X-ray, regular X-ray, need urgent to refer to the dental referral. They need to do splinting immediately if unstable or open within 24 hours. This is displacement injury. We have avulsion, subluxation, intrusion, extrusion, and lateral luxation and concussion. Avulsion, tools completely detached from the socket. Locate the tooth, consider aspirate or intrusion or fractures. If there is missed tooth, you need to examine the chest immediately to consider or to rule out any aspiration there. A primary versus permanent tooth. Avulsed primary teeth never replaced, خلاص gone out. potential damage to underlying tooth bud here. That's what we're worrying about it. Avulsion of permanent tooth. This is really dental emergency, and the patient can lose his tooth. Replace and soak it in the milk or balanced salt solution. The normal saline is better than the saliva. Saliva is better than water. Ligament dries and dies quickly within 1 hour. Yani once you find the tooth outside, immediately put it in milk or saline and take him to the hospital, the emergency. So ligament dries and dies within 1 hour without appropriate care. 85 to 97% survive at 5 minutes. شفت التوث برا وحطيتها في الملك يعني عندنا good chance to reimplant the tooth. Advised to handle by crown. Don't touch the root. Root is sensitive and they carry a lot of nerves and ligaments and they can dry and die quickly. Avulsions, permanent tooth. Pressure gently if the tooth is especially dirty. We can be a little bit worse. Local anesthetic block. Look for other trauma. Don't replace alveolar ridge, fracture, or damaged socket. Gently suction clot from socket, then irrigate, splint, and consider antibiotic. And especially you can cover the anaerobes, like antibiotic can cover anaerobes in the mouth, like clindamycin. Subluxation is luxations, periodontal ligament injury, tooth loose within less than 2 millimeters, displacement, blood, and gingival sulcus. Soft diet, dental follow-up, potential for pulp necrosis. Consider splinting and extraction if mobile, usually facial outside and oral inside splint. Need to intact local dentist to be effective. The dental need to be aligned to be perfect. Oral specialists, they need to adjust it later on. طيب intrusion هذا really emergency. هنا العكس، هنا التوث دخلت inside. So tooth driven into the bony socket, assess if tooth intrude or fracture. The primary tooth, also we consider it as emergency here, less than 3 millimeter intrusion will offer reposition by itself. لكن if 100% it intruded, may need to be extract because this will affect the dental buds here. Maybe associated with alveolar fracture. Observe, usually re-erupt within 3 to 4 weeks. Dental follow-up for damage for underlying tooth bud. Secondary tooth here, it's really dental emergency. Affair for repositioning and splinting can cause necrosis of pulp tissue, will likely need root canal. Extrusion, tooth displays out of the bony socket, primary tooth, extract if very mobile, reposition if it's stable only. A secondary, no, dental referral for repositioning and splinting. Lateral luxation, which is displacement of tooth laterally in socket, often accompanied by alveolar fracture. Primary tooth gently repositions by digital pressure on the crown, only the crown touch it, and opposite pressure on the root, slightly traction. No other intervention necessarily here needed. Secondary tooth, we need to reposition in the emergency and call the dental urgent for repositioning and splinting. What about the concussions, trauma here to the tooth, alignment, tooth not displaced or mobile, but there is tenderness to the percussion. Supportive care only, let the tooth rest, soft diet, and avoid hot or cold. Dental to monitor the tooth viability. I found this website called Dental Trauma Guide. This is from one of the United States University. You know, this very beautiful website here. You can go to they're having a lot of video for trauma and how to treat it, how to do the splint, repositioning. Sometimes also they're talking about maxillofacial trauma, but this website containing a lot of information there. And thank you very much for you. So any questions? Because I know we passed the time now. Thank you very much, everyone. جزاكم الله خير جميعا. So tomorrow, inshallah, we'll meet exactly at 8 o'clock, inshallah. We'll start our presentation with Dr. محمد الفيفي إن شاء الله جميعا. إلى حتى يوم غد إن شاء الله بإذن الله نلتقي جميعا بإذن الله. شكرا جميعا لكم بإذن الله. We finish for today, huh? We'll meet tomorrow, inshallah.